Okay. Members and attendees, we'll start the meeting. Thank you all for coming. This is the committee meeting of Health, Housing and Adult Social Care. And I'm Councillor Myers in the chair. Thank you everyone for coming. We don't have any plans for fire alarms, so the exit's that way should you hear that alarm go. And also the toilets are behind here. Oh, there's a big sign on the door, so you can't miss that. We're just starting, councillor, and so the first item on the agenda is declarations of interest. If anybody would like to declare an interest. No. Okay. Move to second item, which good point, Robert. Thank you. We do have apologies today from Councillor Kelly, who's substituted by Councillor Taylor, and also Councillor Smalley, who is substituted by Councillor Healy. Okay. Agenda item 2 are the minutes. We have got a bumper set of minutes today to sign off. So 2 sets. Before I just ask members for approval and any matters arising, could I just draw your attention to within the first set of minutes in part 11, the finance and performance monitor, the second paragraph, we have just changed a little bit of the wording, which I could read out, but I've read it and I'm very happy with it. It's very minor, and so I'll ask members if that's okay. Or do you want me to read? It's 5 lines. I can do it. You'll see it printed. It's okay. So, are there any matters arising from those minutes, and are members happy for me to sign them? Okay, lovely. Second, Councillor Rose.
Yes, I circulated quite late to you just before the meeting, but on item 17 on the November minutes, it refers to tube twice with the wrong spelling. Okay, sorry, was it just October minutes?
We'll go to that next. Yeah, thank you, Councillor Rose. You have pointed that out. I will confirm that we have spotted that as well, and it has been amended in this printed copy. The TUBE acronym spelled correctly, and there's one more spelling change on item 15 in the resolves. The first resolve, the Salvation Army contract lapsed rather than elapsed. Okay. So I actually moved on to the second lot there. Has anybody got any matters arising from the second set of minutes? Councillor Vassy.
Thank you, Chair. Yes, there were 2 things in the minutes about the Salvation Army report that I think were forgotten. One was that members drew officers' attention to the fact that a number of vulnerable sleepers, rough sleepers, were banned from entering council premises for a variety of reasons. And we expressed concerns about how those individuals would be able to access services if the Salvation Army contract was not involved. And the second one was that members also raised concerns that about the way the contract had been potentially affected by council procurement processes and the definition of key decisions and thresholds as to how decisions are made, which I think is the context which then explains what we resolved specifically about referring it to audit and governance. So I thought it'd be helpful if those 2 things were in the minutes, Chair.
Okay, I'm happy that was correct record of what the committee discussed. Thank you for raising that, Councillor Vassy. That would be a true record if we added those 2 items. Robert, how do you want to go about that?
Yeah, so we'll sign the 18th with the amendments. Yeah. The November ones we can bring back to the next meeting with a change to that one.
Is everybody content with that and the matters arising? Yep. Okay. Matters arising. Councillor Rose.
Yeah. So the other thing that I mentioned in advance, which is in the work plan point it includes neurodivergence within the content around the CQC reports and TUVE, but the conversation was also about the autism strategy coming through, or neurodiversity strategy, and around the ICB and pathway pilot and stuff as well. So we'll get to it when we get to the work plan on this agenda, but just wanted to say that's a slight correction on the minutes, that it was an additional point to the CQC plan report.
Okay, thanks, councillor Rose. Where in the set of min, it's in the resolves, it's in the work plan section at the bottom, resolves. Okay. We'll look at that, bring those minutes back to the next one, and as you rightly point out, we'll discuss that when we get to the work plan.
The specific action that you called out on the day was that you'd go away to think about how it could be incorporated in the work plan. So in terms of what we phrase in the minutes, that's probably the right wording.
Yeah. Okay. Perfect. Okay, we will proceed with that. I should point out that also from the resolutions, we did write to the Chair of Audit and Governance to request that they look at the review that contract process on the draft rough sleeper strategy. Again, you'll see on the work plan that we're penciling that in for March, but we can discuss that when we get to that item on the agenda. And the executive member for housing, Councillor Pavlovic, with reference to the third resolve, he has asked me as chair, and he wants to extend the invitation to the vice chair to meet with him as early as possible in the new year to discuss that rough sleeping policy conference that we spoke about. So we will pick that up as chair and vice chair. So those are the resolutions. Okay. Public participation. Robert, I think we're a great committee, really open and welcome, but I don't think we've got anybody, have we?
No, we don't.
Oh, if you're watching, sign up and give us your views. Okay, and just to note that the meeting is being webcast. It is live and it will be saved on the council's YouTube channel for perpetuity, as far as I'm aware. Okay. We're going to move on, members, to item number 4, which is oral health. And I'm really pleased with the report that's been brought to the committee, and I'd like to hand over to Peter to introduce it and go through it with us. Okay. Peter.
Thanks very much, Chair, and just to welcome a few of my colleagues to the table. So we have Philippa and Jodie here from our public health team, which I'm sure both of them will introduce themselves later on for various of these items that are on the agenda today, but also to welcome some colleagues from the ICB, so Debbie Lebetta from the Integrated Care Board, and 2 of our dentist colleagues and representing the local dentistry committee, Jason and Mark. So thank you very much for coming. Hopefully here to answer questions and to be part of the discussion on the paper. For me, this discussion has 2 sides to it, and wanted to set out those couple of sides right at the start. The first side is what the council, through its public health team, has oversight and responsibility for around oral health. And oral health is, I think it's fair to say, actually probably a bit of a neglected bit of public health, but there are huge links between oral health and poverty, huge links between things like oral health and heart disease, which are not particularly well known. So oral health is a really important topic of public health. The council's responsibilities are about the promotion of oral health. So very much on that preventative side, helping our children, young people, and our adults and our older people to have a good oral health throughout the life course, and using a really relatively small amount of resource in order to do that. The council, of course, doesn't commission dental services. That is an NHS responsibility. Hence, we have very grateful to have colleagues from both the commissioning side, the ICB, who now have that responsibility, but also some providers here of those services to comment on the paper. And what I'm going to do is hand over to my colleague Philippa. She's going to talk about that first bit. So our public health team, the council's services around oral health promotion. After that, I'm going to give a few slides which are up on the screen about what the data tells us about dental provision and dental need within the city, which are produced by the ICB, but they're about population health. So I'm presenting them, I guess, from a public health perspective, and then our colleagues from the ICB are there to answer questions. And Debbie, I probably will bring you in at that point because there is at Annex 1 a paper specifically on dental provision. So just ask you to summarise that if that's okay. So I'll hand over to Philippa, who's going to do the first bit about oral health promotion.
Thanks, Peter. Good evening, everyone. So just a little bit about the oral health promotion work that we do. So the oral health promotion responsibilities came across with the Health and Social Care Act in 2012, when we moved from the NHS into local authority. We are commissioned to provide oral health surveys and also the oral health promotion. And within the paper, I've actually outlined a number of the things that we are actually doing. So just to sort of work through a couple of those things, we have commissioned an oral health promotion service, which works across all the schools and particularly early years in the city, providing supervised toothbrushing, also training and workforce development, and then we're going to be looking at our older people's offer. So we're only into year 1 really. So year 1 we decided we'd start with the early years and then we'd move on to that. So in years 2 and 3 we will be having an offer for older people, care homes and those sorts of things. Just to sort of link oral health with Jodie's service and the other paper on the table today around infant feeding, that we have an offer. It's a universal offer, so every child that's born in York at the age of 9 months, they have a visit from their health visitor, and they're offered an oral health promotion pack. So that includes things like a toothbrush, toothpaste, oral health information, and obviously it gives the opportunity for the health visitor to actually discuss toothbrushing and that sort of thing with the parents. Other areas that we look at it around sort of oral health promotions is through the Healthy Schools scheme, and schools are now mandated to teach about dental health as part of the relationship, sex and health education requirements, and we take that bit quite seriously. So our oral health promotion service does work with schools, secondary schools as well as the primary schools and early years. We have what's called an oral health advisory group, which brings together all the system around oral health. So that includes the ICB and the local dental network, local dental committee, Health Watch, training providers, where we actually look at what the issues are for York and how we can work together to plug those gaps. Within that, we have lots of meetings at the moment, lots of groups around oral health. Seems to have mushroomed recently. So we've got a dental prevention steering group, which is established by the Integrated Care Board, and that's to look at enhancing existing oral health initiatives. So one of the things I alluded to in the paper was they're looking at supervised toothbrushing schemes, similar to the ones that we're doing, but this would give a more enhanced offer, I suppose, because it also gives opportunity for the children to have the fluoride varnish, but also access to a dental service. Our oral health promotion service doesn't do that, it just does the supervised toothbrushing. So that's going to be rolled out across the patch, but at the moment it's being started in Hull and East Riding. Just a little bit about the National Dental Epidemiology Programme. So this is something that happens every year, but every other year it's a 5-year-old survey. So all 250 5-year-olds are surveyed by dental practitioners that go into the school and actually do a physical examination of teeth, and then that gives us some really valuable data. Unfortunately, we've not been able to commission that for a number of reasons. I think we didn't have a big enough budget for one of the commissioning exercises that we did and the tenders that we did, and then we went out again, and we didn't feel that the person who put in the tender was quite ready to take on more responsibility. They're already doing this survey in other areas of the region, of Humber and North Yorkshire. So we really didn't feel that they could take that on. But I think what it has done, even though we haven't been able to secure a provider for that, is open up some opportunities for further discussion. And there is now a regional group that's looking at how we might do that epidemiology survey on a much wider footprint. I think those were the key things that I really wanted to raise. I don't know if there's any questions. I'll hand back to Peter.
Thanks. If you're okay, Chair, with us just continuing with a little bit for questions, that'd be helpful. And I would just highlight one thing in the paper around flexible commissioning that I think it would be just helpful to raise to members. So this is a way of getting for some of our most vulnerable children essentially a fast track route into dental services. We know there are issues about finding a dentist in York and nationally, but this is one small way that locally the public health team has been trying to plug that for at least the most vulnerable children, which is essentially a referral route through both our 0 to 5 service in Healthy Child and through Children's Social Care. So I thought that would be helpful to highlight to colleagues. I'm going to summarise just some of the data around dentistry. I'll hand then over to Debbie, if that's okay, to do a little bit of a summary of Annex A of the paper. So lots of graphs and lots of numbers, and hopefully, if not visible when you get the pack as a follow-up after this meeting. So apologies that some of these are a little bit small on the screen. But this shows a little bit of a comparison about York and particularly thinking about how we compare to the areas that we are grouped within Humber and North Yorkshire, so 5 other local authority areas within that ICB area. And what it shows in our graph on the top left-hand side is adult patients seen in the previous 24 months and child patients seen in the previous 12 months as a percentage of the whole population. So what proportion of the population was seen by a dentist, and this is any type. And the broad message from this is that compared to our national figures, a higher percentage of our child population, but an ever so slightly lower, but it is really only by 1 percentage point, lower percentage of our adult population has been seen within the time period. You can see on the graph on the bottom left about our sort of 0 to 18s and the percentage of the population who are covered. You will see that 11 to 17-year-olds, essentially our secondary school age children, are a higher percentage of that population is being seen than our 0 to 10 years. There's something in there for me about the fact that generally within the first 2 years, you don't go and see a dentist because you haven't got any teeth. So there's something about potentially expecting that proportion to be slightly lower. The graphs on the right-hand side are harder to interpret, but what I want you to do is just, when you're looking at these bands, band 1, I want you to see band 1 as essentially the least severe type of dental activity, so essentially checkup level and routine, and of course moving across to urgent, which is what it says on the tin, urgent care. So we stratify our dental activity into these groupings, and essentially we see that York patients in general, similar to East Riding actually, we see more of that less urgent work in dental practices and more of the routine work. And there's a lot of stuff that might underlie that. And I think the story from these slides, I'd say, looking at them from a public health perspective, is more data and more research is needed, because there's a question behind each one of these data points for me. I think there's something about our mix of activity in York, bearing in mind that NHS dentistry is provided, obviously funded by the NHS or subsidised to an extent, but then there's a large amount of dentistry which is privately funded, and our mix in York may be different to some of the areas we're comparing it to. So we have to take all of these data points with a pinch of salt and ask more questions of them, and very much committed, and I think Debbie would say the same, just in terms of the ICB, to dig down into the data to the extent to which we can for any follow-up queries, and we can give email addresses, etc. afterwards if there are follow-up questions. The next slide shows a little bit about under 18s accessing NHS dental treatment. And on the left-hand side, this is all treatment. And on the right, it just removes all the routine stuff and just has urgent treatment. So obviously the numbers are a lot lower. The proportion of populations are a lot lower on the urgent treatment side. And again, this map asks more questions perhaps than it answers. In some ways, I think you can see a correlation between deprivation and use of urgent treatment, and that would mirror what we see in other health statistics, where generally more deprived populations are likely to see urgent attendances being higher and primary care attendances, the sort of prevention stuff, being lower. However, there are some sort of major areas in which you would say, well, that doesn't necessarily buck the trend. I mean, for instance, Haxby Ward having, you know, a high level in both, Cotmanthorpe having a high level in both. So I don't think we can make immediate conclusions from this, but it does show you that we are able to look at this data on a ward level and can start asking ourselves those type of questions. This is about calls to NHS 111 for dental issues. It's one of the most common reasons to call 111. It is around dental. And again, this shows a link to the deprivation correlation, I guess you might say, but again with some interesting things. So if I just check tick one ward, for instance, Fishergate with the third highest dental 111 calls. If I flick to this one, which is about A&E attendance, Fishergate goes right down to the bottom. So I think there's more work we can do on this to understand some of the trends. Just in terms of the raw numbers, I've obviously presented these as rates, or apologies, the ICB have presented these as rates because wards have different populations. But just in terms of numbers, you're looking at between 100 and 150 111 related calls from each ward, obviously varying because they have varying rates. That's the kind of crude size. Whereas when we go to A&E attendances, these numbers are really quite small, although caveat that obviously every person that attends A&E with a dental related issue, that's potentially not a good story. So when I say small, I don't mean insignificant, but the variation of these numbers, we're talking between sort of 3 or 4 attendances in a year for some wards, 10 to 15 for others. So again, we just have to be careful with that comparing wards between one another when the numbers are a little bit small. This talks a little bit about our waiting list. So people are waiting surgery, mainly oral surgery within Humber and North Yorkshire. There's more than 10,000 people on a waiting list for those surgical procedures in Humber and North Yorkshire, which is quite a large number, I think it's fair to say, and mirrors waiting list issues across the whole NHS. York is tracking sort of middle to high within the pack. It's lower than North Lincolnshire, but it's higher, for instance, than Hull, and it's not often we say things like that in terms of health, our data being worse than Hull. And again, it's quite deprivation linked, so most deprived communities are more likely to be sitting on waiting lists. This shows the number of dentists per 100,000. And apologies to trying to read lines and colours, etc. If you're on the far left, we're the top line, but we quickly become not the top line, if you see what I mean. We're the dark blue line. So we have the second highest number of dentists per 100,000 population in Humber and North Yorkshire, at hovering just below 60. However, the number of dentists per 100,000 population over this 5-year period has been declining, and we are above the England average on the number of dentists. So this is all just a summary. Philip has already mentioned our little bit of a gap in terms of the epidemiology because we're struggling to commission that survey using our existing public health resources, just not buying us the level of care coverage that we need to do that survey. Our dental access in York is below regional average for adults, but above for children. We've got our deprivation correlation, but with all the caveats that I've given, we've got significant waiting lists for outpatient procedures around oral health and oral surgery. And we probably have an above average number of dentists per 100,000 population in York. However, again, I go to that for my previous comments about the mix between NHS funded and private funded dentists. So there's probably more to that story than we have time for today. So that's an overview of the data. This is a bit of a roadshow, isn't it? So I'll hand over to Debbie, who's going to talk a little bit about Annex A.
Great, thank you for that.
And thanks for inviting us to come along tonight. So I'm representing the Humber North Yorkshire Integrated Care Board. And in terms of context, I suppose it's important to say that from April this year, the ICB took on responsibility for commissioning dental services. And prior to that, it was with NHS England. So some of the same team have come across, but people like myself are brand new to the role and to dentistry. So we're really keen to look at what was in place before and how we can work as an ICB to respond more locally, and be open and share things like the data sets that you've just seen, and to really drive forward that change really. When we're talking about what the ICB is responsible to commission in terms of dentistry, it was a bit of a learning curve for me. It's quite a broad range of services. So there's your primary care dental services. So those are generally the ones that you access on your high street that people are used to in terms of checkups and fillings and things. But we also commission community dental services. So these are specialist dental care for patients who can't be managed within a primary care setting. So they might have additional health or social needs, which mean they need to be seen in a different setting and perhaps seen under sedation as well. We also commission intermediate and minor oral surgery. And this is by referral from a dentist. So you have to qualify and be in need of that surgery. We also commission orthodontics. So that again could, thinking of the data that was just shared with that higher portion of children above 10, those might be seeing dentists so that they can be referred into orthodontic treatment as well, because the teenage years are the right time to do that sort of treatment. We also commission urgent care services. So that's the 111 calls. So we actually have providers who focus purely on urgent care support, as well as the NHS 111 call handlers. We fund a part of that service as well. And then finally, we've got secondary care as part of that. So any sort of specialist service required through secondary care around oral health needs, that is something we look at as well. So it's quite a big picture and a big coverage in terms of the dental services. Predominantly what is most likely of interest to yourselves is around that high street dental provision, the primary care provision, and how people within York are getting access to dental services. So we have got 27 practices across the Vale of York, and each of those will be working to different units of dental activity. So that's what we commission. It's unlike a GP practice, so dental practices don't have a patient list. They purely deliver a unit of activity. So actually, once they've delivered all of that activity, they may not be taking other patients, or there may be other factors as to why they're not accepting new patients. We're aware that there are some challenges around that access, and there's a range of issues set out within the paper that we've shared that kind of make nationally the access to dental services quite a challenge. So one of them is around the contract itself. It doesn't give us as commissioners a lot of leeway to manage the contracts more effectively. We get into a series of commissioning units of dental activity, and then at year end clawing back some of the money that's owed and then trying to invest it elsewhere. Up until recently, we've not been able to proactively monitor that and preempt that, whereas the contract does enable us to do that going forward. So probably from 2025, we can actually look at how we want to commission services differently. Patient perceptions as well in that is something that I've talked about, that idea of registered lists. Everyone is used to how you'd access a GP practice. And so it is quite a learning curve to realise that dentists don't have a registered list as well. Also, I think you touched on it, Peter, in terms of free point of delivery. Like other primary care services, actually dental is subsidised, and some patients do have to pay for services while others do qualify for the full payment to be covered. And it's kind of understanding that difference and why that might be. We have got a number of private dental care providers as well. So they are almost unknown to us as an ICB because we don't commission that service. So in terms of data and in terms of access, we don't have any information in terms of those private providers. And we are working to try to build those links and actually start to understand that population. But technically, I suppose, because we don't commission it, we don't necessarily have access to that information in the same way we do with the NHS practices. Despite all of that, we have, I think, in the ICB in the last 8 months, really, since we've taken on dental, we've been able to make quite good progress, and I've got my colleagues with me today in terms of actual dental provision and leading some of those work streams. I mentioned briefly about at the end of a year, we'll claw back any funding owed when dental practices haven't achieved their contract. So we actually have a programme of investment based on the data, looking at areas of high need and where we want to focus our investment. So we have a range of opportunities across York at the minute where we are commissioning extra urgent access sessions. So if the 111 provision urgent access isn't enough for the population, which the data is showing us, we've actually gone out to high street practices and asked them if they can deliver sessions for urgent patients, so 111 can book them straight into the high street practices. We also have a programme of work around flexible commissioning, and Jason's leading a review around what that looks like. At the moment, dental practices have to deliver their units of dental activity, but we can twist up to 10% of their contract value, which enables them to use their staff and their workforce differently to engage in programmes like some of the work Philippa was talking about. They have oral health champions that link in with schools and can help with supervised toothbrushing. But our review of the programme is that actually we want to make that accessible to more practices, because at the moment there's 3 in York, but we want to look at the criteria for that and actually open it up to more practices, and also increase how much they can twist so they're not bound by 10%. We could actually twist a bit further up to 25% of their contract value to fully utilise the workforce and do some more creative and innovative work for those particular target groups or target wards where we need that work as well. We've also got a scheme to look at waiting list validation. So again, practices aren't obliged to keep a waiting list. Some of them do, but not all of them do. And we are asking to go out to them to ask them to validate those waiting lists and then start to open up their lists and invite patients in. So we're hoping to see that be offered out within the next few weeks, so that hopefully from January we can start to see some movement on that. And then I mentioned about the community dental service for those patients who need support really to access primary care due to their health or social needs. We're also looking to invest with Harrogate Foundation Trust, who are the provider in this area, to look at what we can do to manage their waiting lists and increase their workforce to help meet that demand as well. So that's part of our investment plan, is to look at that contract and make sure it's fit for purpose. We're also trying to incentivise providers to offer more. So within their contract, they're asked to deliver a certain number of units, and we've agreed that they can deliver 10% more than we actually contract them for, and that we would pay them for that. So that's an incentive that some dental practices will be doing more work and seeing more patients. We're also planning to go out and develop a service for child-only contracts. So again, this will address some of the gap and access issues for children, and looking at which providers can offer that service. We're looking at private providers in terms of that as well, so that we can really offer a full option really to patients to choose from across the city. And then we're looking at investing in our orthodontics work as well. So we've just gone out to providers last week to ask if they're able to increase their contract activity as well. And we've just agreed where those units will be going. So the offers have gone out to those orthodontics this week. So we should be seeing an increase in that provision as well. Overall, we've got some plans to focus on significant kind of health inclusion groups. So I've progressed some discussions with Clifton House, which is a secure facility for patients with severe mental health needs. So we're looking at what access we can provide to dental services for some of those health inclusion groups. And as part of that, there's conversations as well about refugees or homeless populations and trying to enable access for those specific groups, obviously on top of all the other work that we're doing for the whole population. And then finally, we're really committed to working with our LDCs and LDNs and improving communication with all of our contractors. We're aware that perhaps in the past, the commissioners weren't very accessible. So we've kind of got an offer on the table to do regular contract reviews. If a contractor is really struggling to deliver, we want to know about that. We want a conversation to support them rather than face a contract handback. So we're trying to be more proactive in that. I know we've had probably 2 or 3 of those discussions already in the last 2 weeks. There's more booked in. So we're really trying to engage with that process. And I know my colleagues that are here with me today have seen that difference in the ICB's approach to trying to be proactive and engage with our contractors. And equally, that goes across to our primary care networks. So I sit within part of the primary care team in the ICB, which means I work really close with GP practices, with optometrists, with pharmacists. So we're really keen to see dental integrated into part of that offer. So even things like over Christmas holidays, that we're communicating between pharmacies and dental practices to say, these are the ones that are open. If you need to do a prescription, this is where you can signpost, so that patients aren't having to navigate that landscape themselves, that we're actually trying to help that. And we've got some ideas to do some joint work really within GP practices to use things like oral health practitioners and dental practices and see if we can link their work together to, again, whether it's engagement through schools or through care home providers, a way to do outreach, linking the GPs and dental practices together. So the paper kind of aims to outline all of that and what our investment plan is, which covers all of those off. And then on top of that, I think the group is interested to know, and you're probably already aware, that Rachel Maskell MP is also really interested in the dental agenda, and she had hosted a bit of a summit in August with dental practices to be part of that discussion. So off the back of that, the ICB has an action plan in place. We're following up on the actions from that meeting, of which workforce, child-only contracts, engagement with PCNs and things were some of those actions. And we've got a follow-up with Rachel Maskell being planned for February. So it will continue to be on the agenda for York and something that the ICB wants to continue engaging with to make those improvements across dental as well. So I can open the floor to questions, or if my colleagues want to add anything further as well.
Yeah, we've got questions indicated. I wonder if Jason and Matt, you did want to add anything at this point, and then we'll open out to members. It's up to you.
All I was going to say, I've been Secretary of North Yorkshire LDC for 20 years. In the last 8 months, I think you mentioned mushrooming. The amount of conversations we've had with ICBs recently has been off the charts. For the last 10, 15 years, there's been nothing. It's been treading water. Nothing's happened. It's been ignored. And oral health is a precursor for good oral health. You've got good general health. It's linked. It's obvious, but we've been left out to dry. And that's why we've got this situation we have. It's been lack of action for so long. Is it too late? Some people say there's too many. Once you've gone to the private sector, you ain't going to get them back. And I'm still NHS because basically I believe in NHS. But a lot of my colleagues come out of university with lots of debt and they just see the NHS as a no, it's not going to do that. They're going to go private. And ultimately that's the contract at heart. But the flexible commissioning that is championed in this area, we are probably the most ahead of the curve of all the country with regard to flexible commissioning. And it's because we've been pushing as a group of LDCs to get this over the. We know that the contract is at fault. It's been ridiculed as being out of touch since 2009 from the Health Select Committee. So it's been absolutely unfit for purpose. But the flexible commissioning allows that contract value to do other things that aren't units of dental activity, and that keeps the practice afloat. Because these practices aren't going private because they don't want this, but they've got to pay their staff. And the NHS has been so left to to squander in the outreaches, that it's just come to a point where now we've got some engagement, and Debbie's hit the floor running really with, if you've only been in the job for whatever months, it's amazing how much we have got in the last few months. So it's positive. I just hope it wasn't too late. So we're just all trying to, and working with the primary care, other guys on GPs. I sit on other meetings with our GP colleagues. There's lots of overlap, and having people rock up at A&E is the wrong place. That's just an expensive waste of everyone's time. They're not going to get the right treatment there. They could be treated in primary care. We've got some flexibly commissioned access sessions. So those 111 patients, we had ours yesterday in Kirby Moorside, where patients will ring 111 who are from Scarborough or wherever. If they can get to Kirby Moorside, we will see them that day and get the treatment done. And if they can't be done in one day, they'll get them back the next Tuesday, because it's just Tuesday where we can do that. But that's been commissioned separately out of the units of dental activity, because this contract is so flawed that no dentist in their right mind is going to set up in a high needs area on units of dental activity. I know they're going to fail because they need so much work, and the UDA does not reward in any way that makes it viable. It's just an unviable contract. So the flexible commissioning is a positive, and hopefully we can expand on that. And so it's been good to hear these positive stories coming out just recently, but I hope it will continue.
Yeah.
So, my name's Jason. I've been a dentist in York for 30 years. I kind of left Leeds University and trained here and loved the city. And I have seen probably more activity in the past 8 months than I have over the past 20 odd years with this ICB. I work with the ICB as an LDN chair, so my job is to kind of provide clinical leadership. And my other role, as well as being a dentist, I'm a postgraduate dental dean looking after trainee dentists once they leave university. I think what's important is to understand that the ICB isn't responsible for the national contract, and there's only so much we can do. And when you look at the numbers of dentists per population, even though we might see, oh, we're a little bit higher than Hull, we are still probably near the bottom or at the bottom of the European table for numbers of dentists per head of population. So we've got a workforce problem which the ICB can't solve. We've also got a recruitment problem which the ICB can help but can't solve. And we've also got a retention problem which the ICB can help but not solve. And I think it's important that that context is kind of borne in mind of what we're trying to achieve. We can only work within the existing system. Flexible commissioning allows us to, as it states, flex that system, but to a certain extent. And part of my role, which I find quite exciting, is actually looking at what we can do and how we can push the boundaries, flexible commissioning, to support retention and recruitment of dentists, especially younger dentists who come to our area, and prevent them from basically deciding to defect or move across to the private sector. When I qualified, private dentistry wasn't even on my radar 30 years ago. My career was NHS dentistry. The young graduates today, within a year, they are thinking about private dentistry. And once we need to change their minds, we need to change their mindset. And that is system reform, but I think there's certainly some exciting things we can do with this ICB to actually make it more encouraging and more attractive to stay in the NHS. And that's basically career progression and career opportunities, which is some of the work that we're doing at the moment. And hopefully over the next 12 months or so, we'll hopefully see some of the rewards of that work. I think my microphone was on there.
And then a final point, and if we then open up for questions, is that okay?
Yeah, thank you, Chair. I was just going to add, because my colleagues have reminded me that one of the good elements as well of being part of a primary care team and working with GP practices and pharmacies is that they've got a really well-established workforce recruitment and retention schemes within those sectors. Looking at international recruitments and things, so we can learn from dentistry and what's going on in those other sectors, because the ICB is responsible for them, so we can then apply it across dentistry. So we've got a workforce transformation plan in place, and as Jason said, he's kind of got two hats on in terms of the workforce. So we're doing what we can within the ICB to drive that. And then equally, I was reminded we have just gone out for procurement as well for a new dental service within York, and that was following the contract handback of the Bupa practice in the city. And so we're hoping that the letters will go out to the identified provider at the end of this month, and then we'll start mobilisation from January, looking for that practice to be open in the summer and taking patients. So that is another good news story for the city, that we have secured a provider. So we'll just be starting that process to get things in place.
I really appreciate all the participants. It's really good to get a real outline of your work. So I'd like to open up to members for questions and comments. I'll take Lucy, Councillor Steels Walshaw. I'm really sorry, informality, and then we'll move over to Councillor Runciman.
Thank you, Chair. It was just a query I wanted to ask on the first one, and that was around the universal all 9 months old children having a visit and being offering the Doidy cup and the toothbrush and things. I just wanted to be really sure that absolutely everyone's getting it, because I hear all the time that people are really, I know that health visiting services are so overstretched and people are really, really struggling to see health visitors as well as other health professionals. And I just wondered within that, are the parents, are families identified where there's kind of poor understanding or knowledge around dental health, and whether children with previous tooth decay are possibly identified within this as more of a kind of focus around the family? And I'm aware that was probably a couple of questions. Thank you.
Yeah. Hi everyone, I'm Jodie Farquharson. I head up Healthy Child Service, which provides the health visitors and school nurses in the city. Thanks for having me here. I think it was really important questions. The 9 to 12 month review for us in York is one of the visits that's taken up really quite well in the city. It's sort of in the high 90% of all children eligible for that visit get one. So we know there's fairly good coverage of that visit. So for all those children that have that visit, they get the pack that Philippa described, and that kind of accompanying health promotion and sort of the wider implications of poor oral health education.
Could I just ask if you just pull your microphone closer, that'd be great, please.
Speaking too quietly. Is that better? I think sort of one of the real qualities of health visitors is to be able to sort of, you know, get alongside parents and try to understand sort of motivation and capacity and sort of those support needs. So I think that there is really a good opportunity at that visit to be able to do that and offer additional support. I think the point you make around older children who have had oral health problems is a really good one, and what we're looking at the moment is actually how our health visiting offer blends better with our school nursing offer, and actually that's a really good thing to think about in terms of targeting that oral health approach, looking more, using the data more to think about where those children have been that have had the oral health and dental interventions in the past. So it's a really helpful point. But yeah, I think we're quite strong on that early intervention offer, and constantly talking about toothbrushing. And there's lots of parents that don't realise the importance of supervising and actually doing toothbrushing until children are really quite old. So there's just education at every moment, really. I hope, does that answer your question?
Yeah, absolutely does. I think what I was kind of looking at was the education starts with the parents, doesn't it, and carers of these children, because without that, the message just doesn't get passed along. Thank you.
Councillor Runciman.
Thank you, Chair. Just before I start, if I can just ask everybody to speak into the microphone, because I'm picking it up on the loop. Well, I'm not picking it up on the loop sometimes, actually, so it'd be a great help. 2 questions, Chair, if I may, either end of the age spectrum. In the commissioning overview on page 27 and 30, it talks about vulnerable groups, but it doesn't mention children looked after. Now, I think, and I hope, that children looked after are considered a vulnerable group, and are prioritised. I think that is really important. My second question, sorry, it's on page 34, where we've got nice red lines at the top, or not so nice red lines, particularly the older end of the age group. And what I'm asking you is, do you go into care homes, residential homes routinely, or do you go in when you're called, when they ring you and say, we've got a problem? How can we get those red lines out of the way? And I wondered if you could give me an answer to both, or somebody could give me an answer to both those questions. Thank you.
Well, I hope you can hear me now. So looked after children are certainly part of the inclusion group, and those pathways exist within flexible commissioning. And the work that we're doing in the ICB is to expand those pathways to offer more places for those children. In relation to care homes, there is currently some work going ahead looking at how we can support dentists going into care homes. At the moment, before this ICB took over, that service wasn't commissioned, putting it bluntly. There was certainly under the contract dentists working under, it was removed from dentist contract. So when I was working under the old system, I used to go to care homes every week, and the new contract, which has now been with us since 2006, removed that obligation. And so dentists didn't do it. So the ICB, as part of all the things we're doing, we're looking at re-establishing that, probably through flexible commissioning or sessional access. So you're absolutely right to pick up on that area, and the kind of, as our population ages, as you see the spike, it's going to be an increasingly higher demand for dental services, not just dental services, but all services across York, and especially across Humber, North Yorkshire. So it is on our list.
And I can just add to that as well, in terms of the work with primary care networks, with GP practices, you might be aware that they have strong links with care homes. So if we can get that work off the ground to link oral health practitioners to some of those primary care networks, we can link in that oral health advice and a basic sort of promotion and prevention work to go into care homes via the GP access as well.
And just to further what Jason was saying, when we used to go into care homes back in the day, a lot of people in care homes didn't have their own teeth. So there wasn't the acute problem. People are keeping their teeth well into old age, and they go into care homes, and those teeth are then causing serious sort of pain and discomfort, and they've been neglected for far too long. But that contract was given in 2006, took that away from dentists, and you had to have, you weren't allowed, the CQC made it almost impossible for you to go in because it was outside of your CQC registered practice. So it was almost impossible to do. It's unbelievable how it came about, but it did, and that's where we are. But the ICBs are working to try and develop with the flexible commissioning to try and do this. But it's been a lost talent as well, I have to say. So there's been a de-skilling of the profession to deal with these people who are into care homes. They need different qualities to deal with people who are dementia and all the rest of it, and that's been lost. And it's a shame. That training needs to be reintroduced into and that's what Jason's working with, doing these dental, what do you call them again, Jason, now?
We actually have commissioned my other role of looking after dentists in the lead dental school, gerodontology courses, which cover dementia. So we've started that this year, and that program will expand year on year. But the other thing we're looking to support is the Centre for Dental Development, which is basically providing career pathways and integration of dentistry into both the wider network, but also career opportunities for dentists who might want to specialise in what we call level 2 dentistry, which is the things that normally occur in CDS units. We can actually start to kind of do that in primary care. So again, that's using the existing system and flexing that existing system as far as we possibly can, in the hope that actually we can actually then start to encourage people to do the work that actually we know they want to do, and we know also that will keep them in the NHS, because actually what dentists want isn't money, it's about a career pathway where they see a future for themselves. And at the moment, sadly, in the NHS as it is, they don't see a future. They just see themselves churning UDAs every single day, almost like a treadmill. And it is a treadmill.
Thank you.
Thank you, Chair.
Did you want to point?
I did, yeah. Well, first of all, tonight I've learnt a new word, gerodontology. And secondly, just my colleague Philippa put it in her paper about the oral health promotion service, which we focus first of all on in its first year on the youngest years of life. But just to assure Councillor Runciman that the intention is that prevention work into year 2 and 3 will stretch across into older years as well. So that preventative activity will start, and we'll be able to report back to Scrutiny Committee in future years on that.
I appreciate that, Peter. Thank you. Councillor Baxter.
Thank you, Chair. I have a few questions, but they're a bit all over the place, so I'll let other people go in between. My first one is sort of in relation to you working with the MP for York Central. I just wondered if you'd worked with the MP for York Outer, and given that he probably has much more access to the ministers than sort of Rachel does, I wonder if there could be sort of a joint party, non-party political effort there to sort of help York.
I mean, I'll pick that up, Councillor Baxter. Thank you. And I think it was an approach directly from Rachel, who's obviously has concerns around this issue and brought together the ICB, brought together local authorities, some of our local dental colleagues. We certainly do make representation to government, and in fact I think a couple of years ago the Director of Public Health did write to the Chief Dental Officer about dental provision and to try to escalate this upwards. So I would certainly advocate for us to use the levers we have locally with national colleagues to make sure that this is high on the list, that we're making sure that York's voice is heard within that. The mechanisms to do that might have to be worked through, but that would certainly be something I'd recommend we keep that sort of pressure up, because we do know that for the residents of York, this is a really, really important issue and one people feel very strongly about.
Councillor Baxter, do you want to add another one onto that, or should we come back? Okay, Councillor Vassie.
Thank you, Chair. I've got 3 questions. Maybe if I do one and then we come back, or whatever you want to do. The first is just for a point of information. The slides you showed us, they were about NHS dental treatment. They weren't just about dental treatment across York, private and NHS, or were they?
So some of the data in there referred to all types of NHS treatment, particularly, for instance, when it talked about A&E, that was obviously all residents and patients seen in A&E as in a secondary care setting obviously are receiving entirely NHS treatment. There's no private aspect to that. Some of the other bits in there, or we can get some clarity exactly what that data refers to, but I understand it's about all dental activity, for instance, the units of dental activity slides in there, but we can get clarity on that, and Debbie, we can cover that. I don't know if you'd like to add anything to that, Debbie.
I just want to be sure I've understood when it says 61.3% of children have seen a dentist and 39.7% of adults have seen a dentist in the past 12 months. Is that under the NHS or is that everything?
I would imagine you have no data on private. That would be my guess. There is no data. The General Dental Council don't know how many private dentists there are. They know how many dentists there are, but they don't know who's doing. I could do 1 unit of dental activity and be counted as an NHS dentist, but I did 1 unit. I did a checkup in a year. So the data is they've only just started asking on the GDC registration how much you do NHS private. So I could do private work and I could do NHS, and most dentists do a bit of both. But there's no data to say. So your numbers per 100,000 whatever population is dentists, but you don't know how much NHS is done. So the data needs more data to be able to make the right commissioning decisions.
So just make sure I've understood what I've just heard there. Are we saying 39.7% of adults have seen a dentist is NHS and private, or just NHS? Just NHS, thank you.
So if it says UDA on it, I understand it. It's talking about an NHS funded, because that's not a phrase that's used within private practice. Thank you. Yeah, okay, my apologies. That's slightly confusing there.
That's helpful. If I can just carry on this particular little section. So there's reference in here to checkups and all of that. In my family, I'm with a private dentist, and the rest of my family have got the NHS. And that's just the way it's turned out. I can't say I'm happy about it, but the rest of my family have gone recently from a checkup every 6 months to a checkup once a year. Is that happening to NHS dental patients everywhere? Is that a source of anxiety? I mean, I've got my thought about it, but what are your thoughts about what's happening there?
There was never any evidence that every 6 months was actually needed. That was probably a recycling of healthy patients that was unnecessary. And nice guidance is 3 months to 2 years, and it should be made on an individual basis. So a lot of my patients have been on 1 yearly checkups when I used to work in Whitby for years and years, partly because I couldn't get them in any sooner. There's a crisis. You can't see the same person say you're fine, see in 6 months you're fine, when there's people out there needing treatment. So it's about shifting the worried well, if you like, to a later call out. And there's nothing wrong with it. The evidence suggests up to 2 years is fine for oral health screening, for cancer screening. And if you've got a problem, ring us, we'll see you in. But we can't see everyone every 6 months. And there's actually no benefit in doing that other than easy UDAs, because they're regular patients. And so to make your practice viable, you take the low hanging fruit. To do more difficult stuff is you're not getting rewarded properly. So the dentists have got to look at this and take that what is easier. But there is no evidence to suggest that 6 months is needed. And they're getting that mindset from the public across, because that's been indoctrinated for years. And it doesn't need to happen. It doesn't need to happen. Yearly is quite, and there is a move now. Most practices have been told, move your patients out, because then you can get other people in. Because you haven't got a list. You registered for 2 months only. If I saw you today, you have an access to me for 2 months. After that, I can tell you to go away. That's how the NHS works, which doesn't work. But anyway, that's what we've got.
Thank you. I can just add to that as well. The ICB's identified that communication and messaging with patients is really important as well. So we've engaged with our comms team internally to look at what we can do around website messaging when it's Oral Health Month, raising those campaigns and messaging. So similarly, tackling those sorts of things around recall, because we know that it causes anxiety if you're used to a 6 month recall to then be told it's a 12-month recall. So it's about managing that messaging. So we are looking at options for that within the ICB as well.
That's interesting to hear. Just one little further general point, and then I'll pass over. I've got more specific later. But I noticed there's a bit here about translations, translation services. And I've become aware over the past month that translators in the health service are really struggling, because they get paid for the hour of work they do, but they don't get paid for the traveling. And I've heard people almost in tears over it, because there's such a need for translator services, and they can travel for 2 hours to get somewhere and be paid 20 quid for having been there and having to pay 30 quid to get there. Is that a problem here? And what are your thoughts on how that can be addressed? And is it something that we can do something about in York, or is it only something that can be done nationally?
I personally have had to resort to Google Translate or ask them to come back with a family member who can speak English when it's come across as an issue. The occupational health is a very similar thing. There's access to these sort of things is few and far between, and it affects everyone. And whether it could be done on a national basis or local basis, I don't know. It's becoming more of an issue than it used to be, because the influx of overseas, whether it be from Ukraine recently or further afield, and it is becoming more of an issue. But we've had to use Google Translate and then screenshot it and put it in the notes, so there's an understanding that that's what's been discussed, because obviously someone said we didn't say that, and there's all that informed consent thing. You know, you're telling someone they're going to take a tooth out. It's a one-way ticket to have a tooth out. You can't put it back in, and they want to make sure you've got that message across. So that's how we've got around, because you ask her, so things need to be done there and then. Sometimes you can't wait for an interpreter to come in. They're in acute pain. You need to access and do something, and that has to be done. We've done it through Google Translate. I don't know if that's going to hold up in court, but that's what we've had to do.
Thank you. Okay, thank you.
I'd just like to add about translation services. We've got a pilot at the moment working with my dental trainees, looking at refugee access on the East Coast, and with technology, we got used to that during COVID with Microsoft Teams and so forth. It may well be that actually the actual travel may not be needed for all translation services. So you may be using technology in a different way to actually get more translation services out there more readily, easily. So I agree travel is a problem, but it may be that actually there are other solutions to that as well.
That's very interesting. Thank you.
Just on this, Councillor Steels Walsher.
Yeah, just on the translator thing, I regularly use Language Line, which is an online thing that you have a contract with at your company, and you can tell them prior which language you want, and they can be there online generally. If it's a language spoken a lot, very, very quickly. I know it's not as good as face-to-face, but it is available.
Okay, that's a good point.
That's who we're using, actually. And
Language
they are
Line.
very good. They are very good.
Okay, is next up, Councillor Rose.
Excellent. Yeah, I've one very, very basic question to start with, which is that I have read through all of it. I've been Googling stuff on the side of it as well. And I'm struggling with some of the acronyms, particularly GDS, CDS, and NHS dental practice, which are all numbers of X, Y, and percentages of. Can you just clarify what a CDS and a GDS and an NHS dental practice is and whether any of the same thing?
Yeah, no problem. So GDS is a general dental service. So that's your main contract that most of our high street dental practices are under, and they run in perpetuity. So they never disappear unless that contractor hands them back. CDS is a community dental service, which is that specialist service for patients with high social or health needs where they can't access on the main street in terms of that access route. And then NHS dentists are kind of any of those dental practitioners who might work under an NHS contract.
And so all of GDS and CDS are NHS providers.
Yes, yeah.
There's also additionally private. Right, okay. One other quick clarity question, if that's all right, around whether you've reached out to Julian Sturdy and he hasn't responded, or he's responded but you haven't met him yet, or if you haven't reached out to him at all, if that's possible to clarify.
Yeah, it's a name I've come across, so I know we have engaged with him. And in terms of the kind of the summit in August, which was instigated by Rachel Maskell, we've shared the outcome of that discussion and the action plan with both of the MPs for the area, so that it is, as your colleague pointed out, not kind of political in that. So we're sharing all the information with everyone.
I believe he was invited to that meeting that I attended with Rachel.
Thank you. One quick point and then a question, if that's all right. Not for the first time involved in health in York, I'm impressed by what you guys have been able to do with very stretched resources. And I guess taking that point on board and the point that Councillor Baxter made earlier, it would be great if we had two MPs in York who actually both cared and were involved. And it'd be interesting if the press reached out to Julian Sturdy, how many letters he's responded to saying he is heavily invested in the crisis that people are experiencing when he's not necessarily choosing to respond in full and attend things. But, you know, hopefully a year from now, we'll have some positive news around changes on a national scale. Specifically on a local level, one thing that I wanted the clarity for was understanding around the GDS providers and York's wards and the gaps in them. Noting that the three wards that are most deprived that don't have a practice at the moment, Westfield, Hull Road, Dringhouses and Woodthorpe. That Westfield, Dringhouses and Woodthorpe is a huge area. It's 25,000 plus people and it's one continual landmass in the most deprived sub-wards, if you like, of the city in there. Granted, in terms of the school side of things, in terms of our council engagement, there's a lot of stuff that we're doing in that, but how do we plug that gap? What can we do to facilitate that challenge around the sort of dentist training and onboarding and locations of practices? Because we know from, for example, during COVID with vaccination sites, if you were within a 10-minute walk of a vaccination site, you ended up with half the numbers or thereabouts of people who are unvaccinated at the end of it. So if it's a half-hour, 1 hour walk to the nearest location you could get, there will just be people who aren't going for appointments solely because of that, let alone because of cost. So what can we do as a council or ICB or beyond to address that?
That's a very good question. So prior to the new contract, you could open an NHS spot anywhere you wanted to. You now can't do that. What we are hoping to do across Humber, North Yorkshire is to commission with stakeholders, which is Leeds Dental Institute, Hull York Medical School, my other hat, which is Workforce Training Education, NHS England, and the ICB, Centres for Dental Development, which are basically locations for service delivery for NHS dentistry, which are physical locations placed in areas of high need where we know access is a problem. The first one we're hoping to pilot for pragmatic reasons is probably likely to be in Hull. But you've just identified a perfect area for York. So the idea about these centres is that we actually have dentists working in there, providing NHS dentistry, who are at undergraduate level and postgraduate level, creating a community of dental practice, if you like, integrated with pharmacy, with GP practices, to help them kind of understand what it is to work in a community of high needs, but also to provide opportunities to upskill. And if we can actually train dentists for a long time in an area, we know they're more likely to stay in that area. They may well get married, they may well have a family, they may well have children, and start to lay roots. And that's what a CFDD, so a Centre for Dental Development, is hoping to achieve. We haven't got any national guidance on this. This is part of the Dental Recovery Plan, which the government haven't published. And so myself and colleagues are leading on this. Probably fair to say we're probably one of the few ICBs that are looking at this in any serious way to try and actually start to establish these centres of dental development across Humber, North Yorkshire. So we're targeting areas, and Hull and York is certainly an area where we know there are certain areas where we need to provide access to dental services. So it's not going to happen overnight, but there is a plan. There is a plan, and so
Yeah, and I can add as well, I think things like flexible commissioning give us an opportunity to look at outreach. So if there's not a physical building in that ward, how we can work with the other practices to do outreach in identified areas. So using the data that we've now got access to as an ICB, we can really target where things are needed. So that can be part of our approach to flexible commissioning. And equally, the new contract that we've just secured in York, it has an element of outreach within that as well as drop-in. So if it is a health inclusion group or another group of the community that might struggle in terms of making appointments and keeping appointments, there should be drop-in access to those services as well. So we can look at different ways of commissioning services where there are gaps, and the data we've got will help us do that as well.
Councillor Bassey, on this point.
Just on this point, yes, thank you, Chair. I very much welcome what you've just told us there. One of the villages in my ward, and the points you made about walking, one of the villages in my ward, 1,800 people, just had planning permission for another 150 homes. No doctor, no pharmacy, no dentist, nothing. And what you said there is very heartening, because I think that if all those different things could be put together, then surely the case for creating a centre that does all of that could be made, so people could walk to the services, so that we can cut carbon emissions going forwards, because all of us are aware that we need to get people out of their cars. So I mean, I suspect we all will welcome hearing further developments about this integration as a way of going forwards. Thank you for that.
Thank you. I'll move to another question. Councillor Taylor.
Thanks, Chair. I've got two, but I'll make them fairly quick if that's all right. Thank you. First thing to say is really welcome how all of you have sort of gone about this. I really welcome the information, the honesty, but also the detail on the best efforts that are being made in pretty grim circumstances. So thanks for that. It should go without saying, but it doesn't always happen. My two questions are, the first one's around this epidemiology survey. I think last time this come to this committee or its equivalent, the procurement issue was raised. I think we were going through the Zoom meeting at the time. I have a vague memory of talking through my laptop about it. And I'm wondering exactly when the last time that survey did take place was, and how much confidence we can have in 2026 happening, because that's a long way away still, and whether there's a risk of going to a regional footprint, diluting the data that that survey is meant to provide. So that's, I think, for you guys. And then the second question I've got, a bit more bigger picture perhaps. contract is always raised as a problem, and you've cited this 10% flexibility that's now worked in, which seems to be helpful, and that's positive to hear. But so with that in mind, I'm wondering and perhaps worrying if the helpfulness of that 10%, as welcome as it may be, is there any risk of that delaying a proper system change and getting to grips with that contract system? Because, oh, we'll give you this 10% flexibility, that'll appease the profession for another decade or so. So they're my two questions. Thank you. Cheers.
I'll pick up the first and hand over to colleagues for the second. And it's a good question, Councillor Taylor. And I think the last time that survey produced data for us was 2019, I'm going to say. Philippa?
I think it was before that.
Okay.
Yeah, I think it was before that. Yeah, I think it's a few years ago. Yeah.
So a long running issue. And I mean, just the scale of it, and obviously Philip has mentioned a couple of procurements, which you can't talk about in detail. But for instance, the order of magnitude between the budget that public health has had to commission this and the types of bids that we've had in have been around the 10 scale. So 10 times the amount that we have has been what we've received in, which is not possible for us to accommodate within the public health grant, which itself is struggling and is very constrained. So I really, to be honest, see the regional route as probably our only option, or definitely our best option for the moment. And from my perspective, it's a really good point about the dilution. I think what we'd be hoping to see from a regional route is by joining resources together, we could get a statistically significant sample of the population, because this is an epidemiological survey. So it is essentially checking and then applying what we found to the whole population to enable us to get down to a good level and understand particularly that key measure of decayed missing filled teeth in our children and understanding what that would be. But we wouldn't be putting any of our public health resource into a survey that couldn't give us the granularity of data we needed. So in a sense, probably a bad survey is worse than not having one. Yeah. So we're definitely going after a good joint option. Philippa, I don't know if you'd add anything to that.
Yeah, just to say that the epidemiology survey is kind of very well structured. So there is a minimum sample. The way the schools are selected is done on a very scientific basis. So you have to go to school 1, then school 2, then school 3. So if school 3 doesn't want to be involved, then you go to the next school. It's not kind of so random that you can just pluck a school and go there, because it might skew the results. So it's quite a robust process, and it would be a minimum of 250 children within York that would have that individual examination.
Do you want to pick up on that second question? Because you've articulated very well what the BDA have been saying for years. Now, the BDA, the British Dental Association, are our negotiators with the Department of Health. So we came up with flexible commissioning 2014 and 15 for this area, and we took it down to the BDA to discuss it, and they didn't like it because it could undermine their negotiating for a better contract. We're at that point now where that contract, that was 2014, and we've still got it, and nothing's going to happen with this government. I can guarantee you, if you get Julian Sturdy, he won't be able to. I've been talking to my MP, Kevin Hollingreich, and he has been lobbying as well on behalf of the dentals, because he's got problems in out of York as well, in Malton area. They don't know what to do with it, so nothing gets done with it. In the meantime, dentists are leaving and leaving and leaving. The ship is going down. So this flexible commissioning is the only life raft that's out there. Now, it may just give a bit of time for a better contract. I think everyone knows, and I've spoken to Rachel Maskell, was invited to our LDC AGM just a couple of weeks ago. She understands fully that this is a sticky plaster. It's not the answer. It'll never be the answer. We do understand as a profession, we need widgets to be counted. Treasury need widgets to be counted, but the widgets we've got are the wrong widgets. There needs to be other metrics that need to be counted. At the moment, the flexible commissioning allows these sessions that we do for urgent access to be done in a different way of measuring. So we're measuring the number of patients coming through rather than what you actually do in them, which is a helpful barrier, reduces the barriers to the UDA system that we've got. But I agree entirely, that was a big worry from the BDA's point of view, is if we get this flexible commissioning in, will it sort of say, oh, job's done? It isn't job done. It's just a little bit of let's keep it alive for a bit longer till we maybe get a commission. And everyone knows that is a risk, but it's the only thing we've got, because otherwise, if we don't do that, there'll be even worse a problem.
Yeah. Thank you.
Okay, thank you. I've got a few more members indicating. We can take those questions and then we'll look to wrap this section up. So I've got Councillor Baxter, Councillor Vassy and Councillor Rose. If anybody else does want to jump in, then please do indicate. But if we can work towards moving our meeting forward. So Councillor Baxter.
Thank you, Chair. My question is about students. As a student myself, I stayed registered back home, which isn't too far away, but it means I have to go back home for that, which one is a pain because I couldn't get one here. But also I wonder whether we're sort of missing off those, I mean, a huge group of students, sort of 19,000 at the Uni of and 10,000 at St John's, whether we're sort of missing off people that are having to go to A&E because of dentistry problems, but we're not already sort of aware of them going on in the York area, because I know a lot of students don't register their GP here, let alone their sort of dentistry services. So I'm just worried about us missing out on those sort of numbers.
Oh, I'm happy to sort of just tackle that as best I can, Councillor Baxter. I mean, I think you've highlighted a really good point about health data in relation to the City of York, which is that we obviously have, in that sense, a population who move in and out that other cities don't see to the same extent, because the proportion of a population who are students is very high. I definitely think that there is definitely work that we can do, and we have an active student health network to encourage people either to stay registered where they are or to use the online NHS finder for dentists to see what is available in York. Obviously, if they do choose to do that, they might struggle to do so, as this meeting has highlighted. And you're absolutely right that some of the data that we present, again, it's all about the caveats, isn't it, with these data? They might have missing people within a need that's not absolutely present because of our student population. I can take that action back, actually, because I do know that as part of some of the data presented here today, we do have dental public health consultants. They're very few and far between, but they do exist, and we have a couple within the region for whom it might be useful to ask what do they think the impact of our student population have on this data that we've got. So I think that we can take that back to Martin Ramsdale, our local dental public health consultant, to answer more fully.
Okay, thank you. Councillor Vassy.
Thanks, Chair. I want to get back to the practical thing with primary schools. On page 15, it mentions supervised toothbrushing. And on health scrutiny, nearly 2 years ago, we called for a programme, a trial to take place. And Fiona Phillips set out what was going to happen. There's a brief reference to it here, but what I was told was going to happen, we'd go through a training for school staff to buy the resources. Children will get a new toothbrush 4 times a year. Toothpaste will be provided, special receptacles for toothbrushes to be stored in, and a trial across 6 schools and Applefields and Hobmore Oaks, I think. So that was the last I heard, February this year. It was happening and it was taking place, and we were very keen to find out what had happened, what the results are, and whether you think that can be expanded, whether it's continuing, how it's been welcomed by the children and by the parents and by the schools indeed.
Yeah, absolutely. I can take that question. So that is the Commission service, the Oral Health Promotion Service that we've put in place. So that started just about a year ago. Each year we have sufficient funding to go into 6 schools and the 2 special schools, or 6 settings, I should say, and the 2 special schools. We did a bit of triangulation of data. So we looked at those schools where there was a high proportion of free school meals, where there was perhaps less access to dentists. But also we took some of the quick wins, some of those schools that had actually come to us and said, we'd really like to do this. So those schools have somebody go in, teach them about how to do supervised toothbrushing. We provide The toothbrushing pack's 4 times a year. So it's each term and then one for the summer. And they have toothbrushing racks where there's a whole infection prevention and control procedure that has to be followed. So and that's part of that. So all of that is part of that programme. We don't just go into primary schools. We've been looking at early years settings because we recognise that some of those younger children are probably where we need to start, and some of the other programmes that are coming in that we've talked about do focus on schools. So by targeting our early years, it would just sort of help maintain that response. So that's what we're doing. There's a little bit of feedback that I put in my paper right at the end, where we've got some lovely sort of comments and what have you from schools that had wanted to do it, that the dental service had said that a number of parents had said that because children were now doing it in school, they were much more confident about doing it at home, and that hadn't been quite the same battle as it had been because it was kind of normalised now. Some children that wouldn't engage at the beginning now do engage. We've had in every school or every setting 100% consent to take part, so nobody's actually opted out, which is great, and probably the most positive bit, really, that everybody's welcome that. And there is information that goes back to parents as well, and information that parents can actually use. I mean, we send them different tools and things. So there's Brush DJ, and I'm sure a lot of my colleagues will know where you can, love Brush DJ, so you can upload a 2-minute song of your child's choice, and they brush along to it. So there's lots of things that we try and engage, and you wouldn't believe the amount of Peppa Pig or whoever who does toothbrushing videos. It's quite extensive.
That is really good to hear, Chair. And just so this scrutiny committee knows, this is something Scrutiny called for a couple of years ago, and it's happened. And I'm really delighted to hear that it's working. I know that I spoke to a couple of dentists who said they would be happy to participate in helping chivvy things along. There were concerns that it would eat into the school day, and how would teachers fit it in around lunch? From what you're saying, it's actually, they were just fears that have not materialised, and it's all working well. Is that correct? And
Yeah,
so
I think
I'm delighted.
there are a couple of schools that have said actually it'd be difficult for us, and can you come back to us? There's a couple of early years settings that have said we're quite low on staffing, so we need to reconsider about how we might fit this into our day. Nobody said absolutely no, definitely not ever, but some have wanted that bit of time. So, but yeah, generally it's been a really, really positive.
Thank you. I look forward to hearing it spread across the whole city.
Thanks for that, Councillor Vassy. Yeah, my children are slaves to Hey Dougie's toothbrushing song, which I'm happy with that. Okay, last one then, Councillor Rose.
Thank you. And just correcting a point I made earlier, I guess, or adding to it, noting that the bulk of the other wards that don't have an NHS dental practice at the moment, Hull Road, Heworth Without, Fulford and Heslington, Osbaldwick and Derwent, Strengths or Weldrake, they also are one massive geographic area as well. So we've got 2 big pockets, and rural west bordering Westfield as well. And Cotmanthorpe bordering during as well. So there's 2 big chunks there. And I guess one additional point to note on that is they're both transcending the borders of York Central to York Outer. So again, I'd suggest that if Julian Study wants his secondary job to stay there in a year's time, then maybe he might want to start taking this seriously. But what I really loved about the report was the detail and the number of things that I hadn't heard of, and the really positive things that are scattered throughout, and a lot of myth busting for what I've heard on the streets and anecdotal stories you hear day to day. And the work being done with children, and some of those numbers they're a lot higher than I thought they would be, actually. Have been really good to see. And I just wanted to ask for a final bit of myth busting, I guess, from my side, which is we hear anecdotal evidence all the time of, for example, people who can't get emergency dentistry for weeks or months, or people who are self-dentistrying with drills at home, and all these kind of crises things. Now, obviously, we've seen the stats of the number of dentists going down over time in York, and the number of emergency dental needs increasing over time. But moving away from just the stats and the charts, anecdotally or subjectively, but in terms of what that means on the ground, what are the kinds of things we're seeing? What's the difference between A&E versus emergency dentistry? Can you paint a picture for what is happening in York and which things are improving? You know, better dentistry at home for children, and which things perhaps are worsening and we need to be really mindful of going forward. Sorry, that's a long last question, Chair.
Thank you.
So some of those questions require better data. So we've got high level data at the moment. So I think there's a need for better data about what we do know in total number of patients attending A&E in a certain time frame. We do know access to 111, and that's the kind of plan that the ICB are currently working towards to address those numbers. I think your question also is probably bigger than just A&E and 111 though. It's access to dentistry. And that is a difficult problem to solve. And flexible commission can only go so far because of all the very things we talked about at the very beginning. We haven't got enough dentists. It's not funded properly. The contract's not great. So there's only so much we can do. And that's just being honest and realistic. We're not going to be able to give everybody access to a dentist when they want it. So we're trying to prioritize urgent, vulnerable children, because actually these are the people that society should care about the most, and people that are in pain. But until there's a major contract reform and we've got more dentists and we've got more funding to provide access to everybody who needs it, it's probably not something we can do within the gift of what we've got to work for. But what you've raised is a very, very important point, is actually people just want a dentist, and actually what does that look like? And some of that's part of the nice recalls, you know, improving capacity by communicating to patients. You don't need to go to the dentist every 6 months. Once a year is okay. But we also know that 50% of the population perhaps don't go to the dentist. We also know that funding for dentistry is only funding for around that amount as well. So the government isn't funding for 100% dental provision anyway. It's only funded for about half the population anyway. So that, with that fact in mind, you can understand why we need to prioritize, why we need to focus on vulnerable groups, urgent care, people in pain, and the vulnerable, because actually they're the people probably that slip through the nets most often. But it's a very good point, and I haven't got an answer, I'm afraid, for that, for everything you just mentioned. But
the way we measure how effective a system has been is the drop off the number of MP letters that the ICB have received, and I think the access sessions have made a dent in that, because the patients who can't get access ring their MP, the MP rings you lot, and then things magically sort of happen. I've just had one from not this area we're trying to sort out, which is a patient who's trying to get access before she goes on to very difficult cancer treatment. You need to be checked out to make sure there's no treatment needed before you go on these drugs that can affect healing after an extraction. This patient hasn't got a dentist. And because an MP's been talked, got in the system, it's happening, but we shouldn't have to jump when this should be a system that could be, and it will be, commissioned. We talked about this very issue with biphosphonate treatment before, about commissioning things for, but it has to be targeted. You can 56% is what the population is being funded for nationally. So there's half the population, but there is a sector of private dentistry that we don't need to take people out of the private sector to put them into NHS. We just need to make sure that people who can't afford it, private sector, can access NHS, and it's targeting those groups.
Okay. Yep.
Yeah, just one slightly, well, somewhat more targeted question on the points that you just made. We've got the challenge or crisis or growing need across non-emergency, and that's very clear. And the conversation, the myth busting of the sort of 6 to 24 months and all that sort of things will help alleviate it. Some of the more prioritized need will help as well. Do we have a crisis in emergency as well, where people, when they have an immediate need, can't get the need they have? Or is it just anecdotal, one-off, occasional things that kind of will always happen? There'll be always something that happens that goes wrong. Are we in a crisis in emergency care as well as kind of preventative care, if that makes sense?
Yeah, I'm happy to take that one. I think in terms of the ICB, we do commission the urgent dental care access, which is a purely bespoke service to deal with that emergency at that time. We haven't got a provider in York. So we do have a budget set aside that we've got ring fence for that. We're looking at it, had a meeting yesterday about it actually, to see what we can do and how we can address that. So there is that gap where we do have the money there, but not a provider in place yet. Which is why we're able to use flexible commissioning and the access session options to bolster that. So we have a number of practices at the minute who are taking part in that, so that when they do ring 111, they can be slotted into a variety of practices and seen relatively quickly. So we do have things in place to address that. Our heat maps are variable, so sometimes they show, yeah, we've got the ratio correct and there's not a crisis. Other times the ratio is not right and there is a peak and there's more calls than we're able to meet. So that's why we're looking at what we can do with the funding that we've got set aside and say, actually, we do need it. We can see from our heat maps that there is a need. So we are looking at what we can do around that.
Okay, thank you. Pleased to welcome Councillor Coles, the Executive Member for Health and Adult Social Care. Would you like to make a contribution, Councillor?
Sorry, thank you so much, and sorry for being late. I just thank you again, because we had a meeting last week. In fact, we've been having a number of meetings, because I one of my things that I have not stopped going on about in the last 6 months has been dentists. And just to pick up on the point you were raising about emergency pathways, it is one of the things I am, as you know, extremely worried about, because there isn't a York emergency pathway currently. And so residents, certainly in my ward in Westfield, are being sent to Scarborough when they need emergency provision. And one of the things I'm particularly worried about is that if you don't have a dentist and then have an emergency, it's a double inequality. So you don't have a dentist, so you're less likely to have had a routine appointment, and then you have an emergency, and then you get sent to Scarborough. So it's a kind of compounding inequality. And that's the reason why that particular pathway is a real concern. And I'm really pleased that you're looking at commissioning that locally, so that people in York will be able to see a dentist in York if they have an emergency and need emergency treatment. Just while I've got the microphone, a couple of other quick things. The other two groups that are really worrying me are, I know that the public health team are really on it with the primary school children. I am worried about the secondary school children, because those are children who possibly have been, went through COVID, perhaps didn't see a dentist at the end of primary school, and are now in the latter years of secondary school and maybe still haven't seen a dentist. Goodness knows what is going on in their mouths as they consume all kinds of, sugary things that, are probably not great for their teeth. And when they're not listening to their parents, when they're telling them that they need to brush them. So that is another kind of group of people in the city that I'm worried about. And the other group also that I'm aware of is pregnant women. And if they don't have access to an NHS dentist when they're pregnant, certainly my own experience was, you really need to be seeing a dentist when you're pregnant. And at the moment, I'm not aware of any NHS dentists in the city that are taking pregnant women on as patients. So those are three groups still. We are doing really well locally. There is some real progress, but as people have set out this evening, it is still pretty bad, and there's a lot more that we need to do.
I really appreciate that, Councillor Coles. It's good to know your priorities, and so thank you for joining us. And in outlining those three priorities, we'll make note of those, and a future meeting we can discuss how we are progressing. So it's really important, and thank you for that. I think with that, I'll wrap up this section. Yes, of course, bring you back in.
Sorry, it's just really quick. I was going to add, because apologies, you probably missed at the start, Peter shared some updated slides based on some feedback, which has data on the teenage group of population as well. So that will come out after the meeting.
Thank you for that. For members, we want to note the report, and we want to express a continued desire to work with the ICB and partners to increase the access to dental services where possible, and to support work to prevent dental decay and improve the oral health of our population. And we'll do that. We'll seek opportunity to do it again at a future meeting next year. And we'd really appreciate your time in attending. It's so valuable to us, and I can't stress that enough. And I would say we really do welcome the work of the ICB since taking this on last year. It's really clear that progress is being made, really positive progress, and so I think it gives this committee assurance, and we'll try to feed that out to our residents, of course, by continuing to work on it and to work together with you. So it's much appreciated your attendance this evening and the work that you're doing. Is that okay for everybody before we move on to the next section? So thank you for attending. Do feel free to leave if the next two items are not to your liking, or whether you have got other things to do. Of course, that's everybody's time is precious. So thank you. Okay, members, we will move towards the next section, which is.
James, sorry about that.
Yeah. Okay. We'll have 2 to 5 minutes break and then we'll keep going. We are going to move to agenda item 5, breastfeeding and infant feeding. And again, I'd like to turn to Peter Roderick to introduce this item, please.
Thanks very much, Chair. And it's good to have my colleague Jodie with me, as I said, from the Healthy Child Service, who had a huge input into this agenda. I won't sort of go over the paper at real length. My colleague Natalie, who unfortunately can't be here, leads on this for our public health team, and so has written it and put it together, and I'm sure will be very happy to receive any questions or comments that I can't directly answer. I mean, suffice it to say that the breastfeeding is an incredibly important part of human health, and that is irrefutable within the scientific evidence. The benefits that it confers in the very early years, but then tracking through actually into later life are again indisputable. But it's also a topic that you have to handle very sensitively, and I would try and endeavour to do that this evening. There are huge issues of personal choice. There are huge issues of for those who cannot breastfeed, that being a painful thing for them. So just want to acknowledge that our breastfeeding agenda from a public health perspective isn't by any means in any way trying to hide that fact. However, as public health team, in line with the WHO, in line with pretty much every public health team in the country, we do seek to increase the rates of women breastfeeding at birth at 6 to 8 weeks and for as long as they feel it's appropriate and helpful, and look to address the inequalities in that, because that is probably the thing that worries me the most about some of the data that we see, is that our trends are very unequal, and they are internationally and nationally there. So the paper sets out some of the key issues. It talks about local priorities and national priorities. It talks a little bit about barriers to breastfeeding, and we know that UNICEF, World Health Organization, have done a huge amount on that. One of the barriers to breastfeeding, which is shared across a number of different public health areas, whether we talk about food or alcohol or tobacco, is the presence of a very lucrative industry internationally around formula milk. Again, the sensitivity being that for many families, including my own, in fact, formula has been a part of our journey. However, we know that many companies make an awful lot of money through formula milk and the marketing and the advertising of it. And so we actually have particular things we are bound by as local public health teams and nationally around conventions in terms of appropriate promotion of materials, and there are restrictions advertising wise nationally. So I'll draw attention to that a little bit. Tackling health inequalities is one of the section of the paper. This sets out familiar public health stories about the link between deprivation and breastfeeding rates. You could substitute a number of other public health indicators there. I will apologise for the graph which shows the wards, which I look at it and has a data point for each ward, but then for some reason the names of the wards have half of them are missing. So apologies for that, and I can provide that graph with the updated names. I think it's just sometimes the way these things do, and it wasn't picked up. But I think the picture it tells is quite clear. We link a little bit to food insecurity within the paper. It's definitely an issue we're very aware of. Again, back to that commercial determinant of health piece, that companies are not really incentivized and are certainly not acting to keep prices of formula milk down, and in a cost of living crisis, actually the amount of money and out of your sort of income that you'll pay if you are formula feeding per week for infant formula is quite astonishing. Actually, it's a huge amount, and we know that is causing real poverty issues for many of our families in the city and nationally. And we know that actually leads to very understandable but possibly quite worrying choices in terms of watering down formula and things that we'd want to encourage from a public health message people not to do, but then actually if you can't afford to not do it, it's a real bind. We do, however, have a breastfeeding and infant feeding delivery plan and some active work on this, which is really good to be able to update committee with. We've put in a real summary of the plan because we didn't want to bombard your paper, but sitting behind this, there is both a multi-agency group, an infant feeding partnership, drawing partners together, and quite a robust infant feeding plan, which we've summarised point 28 around the 4 areas of protecting, promoting, supporting and normalising breastfeeding within the city. We've also obtained some resource coming into the council from the ICB, which is really good, given the squeeze that we have on council funding and also on the public health grant, which was increasing by 1.3% this year, which does not match any way inflation. So it's good that the ICB are able to step in a little bit, resourcing a program of work. It's about breastfeeding, it's about infant feeding, achieving the baby-friendly initiative accreditation is one part of it, but it's really the icing on the cake. It's not, the point is not necessarily chasing after an accreditation. It's about doing the work that gets us to that stage. If we were accredited, we'd join the 91% of other health visiting services in the country that are, so it is quite a common thing to be doing. At this stage, I'll give Jodie a chance to say anything I've either forgotten to say or said incorrectly.
No, not at all. I think the point you make about choice is a really important one, and I think it's why we call it an infant feeding strategy, not a breastfeeding strategy. And I think for us as a health visiting service, we're really pleased that we've got that funding in now to sort of really develop the workforce and start, you know, small, but we're thinking beyond health visiting. We're thinking about the family hubs, we're thinking about the city, and we've got a really good person joined us in post now as an infant feeding lead as part of that funding from the ICB. So we've got some capacity and some leadership to take that forward. The point around the infant feeding insecurity issue is a really challenging one. We want to be able to make formula milk for formula fed babies available when families reach crisis, but we also want to make sure that it isn't just a sticky plaster offer, that we've got some wraparound around that. So part of the work we're doing in the infant feeding project group is to make sure that it isn't just here's a box of formula, off you go. It's making sure we're linking families into the right services. So we've got the right people kind of around the table now to do that. And that is really positive work. I think that's probably all.
Thank you both for outlining the work there. Could I ask members if there's any points? I'll take Councillor Wilson and then Councillor Taylor.
Thank you. My question was just around the food insecurity. So I know that like York Food Bank won't take donations of formula milk because of the UNICEF guidelines and making sure, but I was wondering, and I don't know exactly what happens, but in those local community food banks and places where people can donate food and then people can take it away from, do you do any work with those sorts of food banks about not just having formula milk available?
It's we started this conversation last year, really, sort of with sort of the coming out of the pandemic and into the cost of living crisis, when we realised that this was a real issue for families, and we realised the barriers for it seemed the obvious place to have a sort of a crisis emergency. But as you rightly point out, there are some policies that restrict that. So part of the pathway that we're looking at is how these key points in the community food banks, maybe citizens' advice, local area coordinators, community hubs, just sort of key points within the community where people might show up, GPs, in crisis. So they're all aware of where you can get directed to 24/7 access of emergency when you're in crisis, but also how you get looped into, for example, health visitors who will go out and make sure that we've got the support we need to make sure that, you know, everything that's in place that can possibly be to try and avoid that crisis recurrence happening. And because of that sort of citywide community approach that it needs, it's just not an easy fix. But as I say, I think we've got the right people involved now, and there's a real kind of good appetite to support us with that work. It just might take a little bit of time. Sorry, Peter, go on.
Well, in fact, thanks, Jodie, you covered that really well. My sense is that it does need that mixed approach. It would be very easy to flood some of these community provisions with formula and just say, there we go, off we go. The paper demonstrates that our more deprived communities have lower rates of breastfeeding, and we've got to hold those two things in tension a little bit for me. Absolutely, we want to make sure that our babies are fed, and we need to ensure that provision is there. We also need to think about the long-term tackling of those differential rates between deprived communities, non-deprived communities. So without the sort of almost the whole system approach that Jodie has demonstrated there, that has that sort of prompt to check out a peer support group around breastfeeding, because ultimately, if it is possible, it is by far cheaper and much healthier. So I guess it's a tricky balance to get right, and provision of formula is part of it, and that has been part of public health work, but it hasn't been as easy as just saying, well, we'll purchase a lot of this formula, we'll flood the sort of community market with it, because we've got to provide the support along the way.
Councillor Wilson.
My understanding is that if you're following BFI, that you cannot do formula milk through community banks anyway. It's that it should be. So we do need to have some capacity for those people who are really struggling to give them formula milk. I know that there are vouchers available if you have a certain income, but
I can't speak on behalf of third sector organisation, but my understanding is that obviously community food provision in the city is a lot of different food banks with a lot of different types of policies. So I don't think it's the case that all food banks in the city would take that approach. I think there would be a variety, which doesn't mean it's not an issue, but I absolutely pick up your point.
Yeah, if I can just add, I think working with maternity colleagues sort of recognise that their doors are open 24/7. It seems to be that at the moment that's likely to be the place that we can signpost families to in crisis, because you know food banks are only available at certain times of the week as well. But it's kind of about once we have a system in place, making sure that families are aware of it, but not relying on it. We want families to come forward before, and it's a very difficult thing to admit. You can't afford to feed your baby the way that we would recommend, so it all needs to be managed really, really sensitively. But yeah, I think we're on the right lines with it now.
Thank you. Councillor Taylor.
Thank you, Chair, and thanks for this report, officers. A question I've got is around this idea of a supportive culture and how that can be positively used to increase rates. And obviously a lot of work's going in at the sharp end here to make sure babies simply get fed out through whatever means. But on a sort of softer cultural level, what work, if any, I appreciate budgets are pathetic across so many public health areas and many other public services, but what work, if any, is going on in York to try and change that culture in places that people just go to naturally in their lives? So cafes, libraries, I don't know, restaurants. Is it simply a case of hoping that businesses will just decide to be relaxed about breastfeeding, or is there any sort of nudging taking place, messaging? I have no idea, so you know I'm interested to hear.
Yeah, it's a huge, we could talk about this all night if you let me, and it's not unique to York, because it's a very sort of whole country problem. I think Natalie, as Pete said, leads on this, and she's really keen that the funding that we've got goes beyond just healthy child service, as I say, family hubs and thinking, certainly sort of businesses and looking after your employees who return to work and are continuing to breastfeed, but also thinking citywide about breastfeeding friendly cities. And there are lots of really good examples across the country. I mean, Hull has got some fantastic actually initiatives that have gone on about how you can kind of encourage businesses to sign up to baby breastfeeding welcome here. It's interesting, I was at somewhere local in York just this week, I'm not going to name it, and in the toilet, in the ladies' toilet, the sign was, "You are welcome to breastfeed here." And I thought, it's a great poster, but you've just got that in the wrong place. So I think is Natalie and myself and the whole public health team with Anna now, our new infant feeding lead, we're really keen for the work we do to get out into the city. But I think in the first instance, we have to sort of think about the workforce, the training, the quality, making sure those messages in those community areas that we're identifying now, where we're having either we're not starting to breastfeed or the drop off is really quite stark. That's the bit that that concerns me the most. We've got women who have got an intention to feed and start to feed, but then something goes wrong and they stop doing that. If that's through choice, that's absolutely great. But for those babies, they might have carried on being fed for longer. So what's going wrong there in those particular places? So there's so much we could do in this area. And I think sort of starting with the workforce and sort of the quality of support is a really important first step. And then we think citywide.
Yeah, thank you for that. Thank you for the question. It's really important. When I was looking at paragraph 28 and the York Breastfeeding Welcome Scheme and trying to work out whether that's something that would lead towards wider citywide thinking and approach. But you've answered that in the question from Councillor Taylor, and I get the point that you're starting with the family hubs and with your staffing, but to build towards a citywide approach using those examples you mentioned from Hull and other cities, I think would be really welcomed by businesses and the city more generally, to create a different atmosphere and mindset towards breastfeeding. So I always ask you to keep that in sight as a goal, really. I don't have a question, but I'll pass over to Councillor Bassey.
Thank you. Well, I'd echo the things that have been said over the past 10 minutes, and I was interested by what you said about best practice elsewhere. And I was wondering, Chair, whether we might just signal that this scrutiny committee would be happy to receive a short report containing some examples of best practice in terms of employers and stuff like that could come to this meeting and then be used as a trampoline to get the message out there, to use the power of this committee to say, no, bring us half a dozen examples of where they're doing it properly, and we can just have it as a brief agenda item.
Yeah, just formally second that so that we can record it and place it as part of our future work. It'd be a really good item to pick back up with those best practice pieces able to discuss. Councillor Wilson.
Just further to that, I was just wondering if you've got connections with the local support groups. I have a vague recollection that when I moved to York, the NCT had a list of breastfeeding friendly places in York that you could go. That was a little while ago. And also like Treasure Chest that runs those breastfeeding support groups. I feel like there's quite a lot of community work already going on, and it would be that would be a cheap way to coordinate and get a coordinated response.
Yeah, thank you. We work quite closely with Treasure Chest, and they're part of the infant feeding project group as well, which is really helpful. And I think when we're thinking about the communities that we've highlighted on the data, there's something about sort of the city and the kind of places that we want our residents to go to when they're out for a coffee on a weekend. But equally, we need to think about the community areas and the places that people from the various different communities would want to go to and know that they can sit down, have a cup of tea, and toddler runs around, they can quite easily feed their new baby. So it's kind of thinking ward level as well as whole city. But we're definitely not in the business of duplicating, which is why it's so important we've got the infant feeding project group and having the right people there.
Councillor Steels-Walshaw.
Yeah, it's a kind of follow on from what Sarah said, and it was about, sorry, Councillor Wilson, about and it was a follow on about the training, because it's got the training in here, and I just wondered, is there a specific training program that midwives and health visitors undertake? And it was along with, because I know that loads of my friends have all used alongside that, because obviously, as you've said, health visitors, midwives are not available all the time. There's specific charities, support groups that help. Is there like a specific ones we use in the city? Thank you.
Yes, so I suppose if I go back to the beginning, the midwives and health visitors as part of their training have to do sort of the BFI, which is a UNICEF training. So they sort of come out from university with that level of training. And then BFI accreditation is quite a rigorous set of standards, which includes the training element. So it's about how we promote breastfeeding. It's about actually the positioning attachment element of it. It's about how we provide reassurance that baby's getting enough. It's very, very relational. It talks a lot about attachment and bonding and baby brain development, and actually that's sort of the nurturing side of it. And that's all sort of that UNICEF accreditation. So that's the training bit that comes with BFI. What was the second part of your question, please?
Sorry, it was about whether there was specific
Yes,
support
sorry.
groups that we recommend,
so-
promote.
Yeah, sorry, apologies. So yeah, the treasure chest is obviously the key one for York, but there's also some national numbers. So 24/7, we sort of promote those with our breastfeeding mums, so that if it's the middle of the night and you're really struggling, there's breastfeeding support lines. I mean, it would be lovely to have a local offer so you can ring someone up in the middle of the night and know that they're just around the corner, but it's something for now.
Yeah, absolutely is. Thank you.
Okay. Councillor Rose?
Yeah, thank you again for all of the reports and the information there, and it's good at myth busting things that I again, not to go on a political rant this time, but I think there's a lot of lack of understanding of, and particularly the 8 out of 10 women stop breastfeeding before they want to. We're talking a lot about choice here, and that's a really big number, 80%. What I'm wondering, and all the work that's being done and all the conversation here is really good, measuring that now and measuring that as things change and comparing us to national levels. I assume that 8 out of 10 is research based, therefore it's a national number or a wider regional number. 44% 6 to 8 weeks in is a powerful metric to track over time as well. Do we have one a year, 2 years later? Is there an equivalent to that sort of 80% drop off that we have in York? I've got one other quick question, which I'll just say at the same time because it's easier, which is on the two charts on page 47, when you compare the two, the one that's got no name at the bottom, the penultimate of the wards, is very, very median on deprivation level, but is the second worst in terms of the percentage. And I just wondered if you remember what ward that was, and if you'd seen if there's any particular reasons behind that and Huntingdon New Earswick being so far down in contrast to the ones that in large part will be driven by that deprivation.
I'm happy to take that question away, Councillor Rose, because I can't recall from the data the names of the wards that are labelled. Apologies for that. So we can get you that data.
Okay.
And on the point around that metrics piece, the same, is that a takeaway one, or is there anything
It is. Well, I mean, I would say what we that some of the data in the paper is looking at, the 8 out of 10 statistic, for instance, is, you're absolutely right, it's based on sort of national surveys and academic research, whereas the next point 19 in terms of local data, that is these things are measured quite formally, both through at the time of delivery will be measured by maternity services, and that's a national metric maternity services asked to collect. Our 6 to 8 will be measured by us, I think, a Healthy Child Service. I looked at this just in terms of benchmarking, and we are around the national average for both those, but that massive sort of inequalities within, I suspect, is higher in York, because that's what we often find with public health data in York, that we're around or a bit better than the national average sometimes on some indicators, but the inequalities are quite wide.
Thanks. I guess the reason I'm asking that question in particular is the flip side of, in point 18, it talks about employers not having adequate provision. That obviously will help drive down breastfeeding levels. The flip side is also going to be true. People who choose breastfeeding over their job, and that kind of gender pay gap and employment challenge that you'll have with early mothers as well. The more that we can engage with businesses and see that change, and the more that our businesses in York in particular do care about these kinds of social issues, the more we can make strides. But if we can't measure it, we can't see the effect of it. So I guess that's the reason I'm asking those questions. That's fair.
Okay. Thank you for that, Councillor Rose. Is there any further points on this item? I think we can move. Recommendation is that we work we note the work being undertaken in both areas, and we will, in addition to that, ask for a short report for a future date to show examples of best practice in this area, so that the committee can see what type of work goes on elsewhere and what we could look towards in the city. Okay, if members are happy with that, I'm going to move to the next agenda item. Yeah, okay, I should say it's not ideal, but I have to leave the meeting. I'm really sorry. And Councillor Vassie will take over the chair at this point. So thank you all. I'm really sorry that I can't finish the meeting off, but I hope you have a good evening. Thank you.
Good place to start. Yes, so item 6, who is going to be speaking on that?
So again, Chair, I think this is me picking
Oh,
this up.
you.
This is
Fine,
the
okay.
item on smoking
Let's
pregnancy.
step off then.
Thank you, and I will endeavour to be brief, though my brevity is in no way reflective of this item and the agenda, because I think it is extremely important, just as our last one was. So we know that smoking is the single leading preventable cause of death. We have 17,000 smokers still in New York, so it's still a big issue for us. And in particular, smoking in pregnancy is something that is going to affect the health of the person who is smoking, and it will very much affect the health of the unborn baby. But then when the baby is born, entering into a smoking household will affect them for the length of time that they are in and probably beyond. So this paper covers a little bit of the work we do as really one of our key top priorities within the Public Health Department in York about smoking in pregnancy. It's not a job done, and it's by no means a problem solved, but hopefully expresses some good news about our recent trends. So we have a national ambition to reduce the rate below 6%. They're actually currently considering reducing that national ambition to 4%. The report notes some of the links between smoking in pregnancy and complications in pregnancy and birth, stillbirth, premature birth, low birth weight babies, so babies who often struggle to thrive in the first months and years of life. The link between smoking and the very sort of tragic eventualities of sudden infant death syndrome and the ongoing health of a baby as they move through life. We have worked for a very sort of good number of years between the Public Health Department and the Midwifery Department, and with our in-house Healthy Child Service that Jodie oversees to try and support and tackle this issue. We provide as a council the only stop smoking service in York, which is NCSCT level 2 accredited, so essentially our specialist stop smoking for all residents, and that applies to those who smoke in pregnancy, although the pathway and the intervention is slightly different. Our health trainers oversee that and they deliver that. The best practice is to provide 12 weeks of nicotine replacement, so gum, patches and vapes. Vapes, e-cigarettes are the evidence shows that they are effective and much less harmless than smoking in pregnancy. So the Royal College of Obstetricians and Gynecologists does support the use of vapes in pregnancy. So we supply all those materials, and then we supply the psychosocial interventions which help people quit, because quitting cigarettes is flipping hard, else people would have done it many years ago. So we provide a lot of wraparound support for that. Point 11 sets out the good news that both national but particularly local smoking pregnancy data has shown the right trend over the last few years, and over the last decade we've dropped from around about 1 in 7 of our pregnant women in York who were smoking to around about sort of 8% of our women smoking. So that's a good trend. It's a trend that is faster in York than elsewhere, and particularly over the last few years. I'll put that down to many things. We have introduced a smoking incentives in pregnancy scheme. It's first trialled in Glasgow. It's been shown to be effective in Bristol. And after looking at the evidence, we judged it was a good use of our resource to put that in place. It is a small financial incentive. It's not huge, but it does give a supportive message and a sort of a wraparound message for our mums, and has been taken up well. We think the work that our health trainer team are doing, the work that we do generally to encourage people who are smoking pregnancy to try and quit, to have another go if they've tried before but it's not worked, is part of that message. And of course, you know, national messages and that general sense of harm is probably reducing to the trend as well. But there's still massive inequalities, as always. And we see that when we measure women who smoke at the time of delivery, the SATOD data, again, that measured by maternity, that we see massive sort of disparities in rates. So there will be wards year on year, and we see this data very regularly, where we're not seeing a single person smoking pregnancy, and wards where we see sometimes it has ranged up to 25% of pregnancies. Thankfully, we're down below that for any ward now, but we're still between Hewitt, Guildhall, Westfield, Clifton, we're hovering above the 10%. And other wards we're talking about no one. We talk a little bit in the paper about women smoking at booking, referred to us in the health trainer service, then those who engage, those who set a quit date, and number who are successful. The good news is that when we do support women to quit, most of them do set that quit date and then quit. But we do see drop off in that pathway. So not everyone is identified during their antenatal journey will come to us or will engage with us. And that's where that financial incentive scheme fits in. The NHS in Humber and North Yorkshire has been running a programme of work for a number of years now, for a couple of years, a couple of years, to implement what the NHS set out in the long-term plan in 2019, that every person who smokes in pregnancy should have an offer of smoking cessation and the NRT that goes with it, that's embedded within their pathway. So we've been trying to transition from the council delivering most of that to the option still being there for the council delivering it, but actually maternity pathways to have it in. I'm the SRO for that Humber and North Yorkshire programme. I've been implementing that across the 9 different pathways of acute hospitals in Humber and North Yorkshire. That programme is getting going within York Hospital. It's very much there within our acute patients. The maternity pathway is taking a little bit longer. So one of the recommendations actually in this paper is just a supportive nudge from this scrutiny committee around our maternity colleagues in York Hospital who I have reached out to, and they know I'm doing this little nudge actually, to just make sure that the trust are able to prioritise that. Maternity is suffering a huge amount of strain and pressure at the moment, but I think delivery of this programme and getting that embedded within the trust does need to be a public health priority for the city. I'll stop there, Chair. Hopefully that overviews the paper, and happy to take any questions on this, and obviously Jodie from Healthy Child Services too.
Yeah, okay, so Councillor Taylor, Councillor, I'm seeing in the order I saw them, Councillor Baxter, Councillor Steelswater, and then Councillor Rose.
Thank you, Chair, and thanks for this report. I think one question I've got on this is looking at that graph and the downward trend, which is positive. I'm wondering if within that we have any sort of data to let us know if those who are still smoking at the time of delivery, are they at least reducing, or are most of them sort of as they always were?
Yeah, that's a really good question, Councillor Taylor. So nicotine dependency is measured by something called the Fagerstrom test, which is an addiction test. And a lot of the academic studies take the time to measure that, because you're absolutely right that not all smoking is the same. Some people smoke 1 or 2 cigarettes socially per year, and others smoke 40 a day. And part of the pathway is assessing where people are starting and giving them the required nicotine they need. So you don't give the same amount of nicotine to someone who does, you know, a couple every week to someone who does 40 a day. Not unfortunately, the way that smoking cessation works is the Russell Standard quit is a nationally accredited way of measuring someone quit at 4 weeks, monitored by carbon monoxide testing. So essentially, if you measure beneath a certain level on a carbon monoxide monitor, you are judged to not be a smoker. And it's a bit of a blunt instrument. So it doesn't necessarily tell you, it tells you whether you've quit smoking, and it can't really tell you whether someone's reduced from 40 to 5 per day, which would be a really meaningful thing. The difficulty is that the way the body responds to nicotine, and nicotine is as strong as heroin. It's a very addictive drug in terms of its strength, not necessarily its harm, but in terms of its addictive strength. And what the body does when you reduce down the number of cigarettes is you puff harder, you draw more of the cigarette into your lungs. So someone smoking 40 a day is actually not drawing as much of the noxious chemicals from each individual cigarette as they are from in 5 a day. It's the way the body responds to the nicotine, and the science behind it is beyond me, but that's the way it works. So actually, we do set a lot of store in smoking cessation by saying, actually set a quit date, and the corny phrase is not a puff. So on that day, not a puff more. We don't say on that day, try 5 a day or try 2 a day. We say not a puff, because actually the drug that is nicotine, which back to my previous point, produces billions of revenue for large multinational companies every year, is very clever at keeping people addicted to it. So a cornerstone of tobacco cessation is not a puff. So in a sense, I almost want to flip the question back and say we are trying to concentrate on keeping the main thing, which is getting people to that 28 days quit and not at all smoking. If they're using vapes or if they're using patches to give them the nicotine, that is so much a reduction in harm that we're happy with that, but we're not really happy with them smoking at 28 days, and they won't be recorded as a quit because they haven't quit.
Councillor Baxter.
Thank you, Chair. I have to say, I find this stuff really interesting because growing up, my mum helped implement some of these policies, so I have such like a special interest in this. So one of the things that I was going to ask about is the opt-out system, because I know it's in Sheffield as well, where I'm from, and I just wondered how sort of effective that is compared to offering the service rather than having to opt out, and sort of what our numbers compare to the national average, if you have those numbers with you.
Good questions again, Councillor Baxter. So the opt-out system, for those who are not sort of aware, is almost treating smoking in the same way that we would treat any other referral. So for instance, in some referrals within health and care, you very much give the option. You say, oh, there's this interesting service, would you be interested? But for instance, if someone turns up an A&E with a certain set of symptoms, you wouldn't say, are you interested in a liver function test? You do a liver function test. It's that principle of opt-out. So it's not saying to people, are you interested? It's saying, as part of the pathway within maternity services, we are going to be giving you support to stop smoking. And of course, if people then say, I absolutely don't want that, they have that choice. Everyone has that right. But it's turning the sort of, it's such a serious issue, it's treating it in that single way. In terms of our success with that, I don't have those numbers to hand versus other areas. And I suspect, I mean, you mentioned Sheffield. Sheffield was one of the early implementer sites for the long-term plan for tobacco. So I would imagine South Yorkshire are a little bit ahead of us, but we are gaining fast in terms of the proportion of smoking mums who are treated through that pathway. It's meant to be at full implementation by next financial year. So we should have all of the 5 trusts which deliver babies, Enlag, Huff, York and Harrogate, and then Scarborough, so the same trust, different units, should be having that within the pathway by next financial year. Should be all are offered that. It'll be interesting to measure how many do choose to actually opt out, because for me, that's something there about the quality of the intervention. The way you ask the question will probably be part of the answer you get. So we constantly need to be challenging ourselves that we're not just, it's not just a tick on a form, that it is delivered well. And that requires really good training and really sensitive work. I mean, Jodie, she would comment about sort of, but again, like with breastfeeding, this is core part of midwifery training, core part of health visitor and school nursing training, isn't it? You would have had that, but it's probably about maintaining the quality of that as people go through their practice throughout life.
Great. And I think we see it with other parts of what we offer. You know, the way you the way you sell something to a service user makes such a difference. So it's about sort of being focused on our priorities and making sure we revisit them with our staff group and in trainings and awareness sessions, because there's so many priorities for our workforce out there. But you know, it's just making sure that the kind of brief interventions that we're doing around smoking and pregnancy just remain priorities.
Councillor Steels Walshaw.
Thank you, Chair, and thank you for the report. I'm just looking at these statistics that go from 2022 to 2023. So there were 131 women who were smoking at booking, and out of those, so there was a percentage referred. 10 had successfully stopped at the 3 months postnatal period. I'm just wondering, because within abstinence from the smoking, 3 months is quite early days. A predictor of someone maintaining abstinence is usually the longer they can maintain abstinence, the more likely they are to stay abstinent. So I was just wondering if there were any further plans for any more follow-up with those people to see if it continued, because obviously if the parents aren't smoking, it is more beneficial for the child. So I just wondered if there was any longer term studies, or if I am wrong and there is another date at how long you've stayed stop smoking that is more likely to predict abstinence. Thank you.
So I think my response to that is I'd be really interested in knowing the answer to the question too. Sometimes I'm finding within my public health career that part of the job is to, but particularly when things have had quite robust evaluation elsewhere, is that implementing them locally, you're not able to collect the same level of data that they are able to collect elsewhere. Now, having said that, I can't guarantee you that the RCT in Glasgow, which was sort of in many ways why Cochrane recommends smoking insensitive to pregnancy, that they did follow up at 12 months. I would be surprised they hadn't, actually, because 12 months is usually considered the next stage of follow-up. So I imagine they did follow up, and I imagine it showed that more women were quit than if they had not received the intervention. So in a sense, we take that sort of off-the-shelf academic thing and we try and apply it here. And I suspect trying to follow up at 12 months would be just another resource drain on us, that in a way we're trying to trust what the evidence has said around the effectiveness of intervention. But it would be interesting, and I think I guess the public health message here is that people do quit, people do relapse, but that's okay. You can quit again. Actually, the one piece of evidence which has been from behavioural insights over the last few years is that the problem with smoking cessation is the lack of hope of people who have tried a number of times. And actually part of the public health messaging is a balance of harm and hope. We do need to talk about harm. We do need to talk about the fact that this is so super dangerous, and pack labeling, the horrible photos that you will see on a cigarette pack is part of that. But also we need to communicate hope as well, that, you know, 3 months successfully quit, that's great. If on the 4th month it all goes wrong, that's fine, you can try again, and that, you know less likely to succeed. And that message of hope that lots of people are many years smoke-free now who tried 20 times and then they cracked it in the last time, and that's possible. So that message of hope, I think, is important to communicate.
Absolutely agree. Thank you. I think it's about letting people know that they can go again, that it's not a one-time offer. Yes, thank you.
Is it supplementary to that, or okay? So Councillor Rose first, then.
Yeah, mine was kind of supplemented and kind of answered, but I guess just to ask it anyway. The same point around how many people out of that 131 down to 41 would benefit from another re-engagement of the same approach, or a similar approach. It's kind of a different angle on 1 year later. Do the people who don't receive that help go, oh, I really wish I did have that support? Is the drop off because people are like, I'm a smoker, I've always been a smoker, that's a genuine choice, or I'm too busy being with all the stuff that I've got going on to engage? Do we have any idea around that? Is there anything we're doing that we can do more on in that area?
So going back to people who've formerly been in our smoking cessation services, and we know have relapsed, is absolutely a really common tactic of smoking cessation services to get to those who are most likely to benefit and also be amenable to the quit attempt. So yeah, absolutely, Councillor Rose, we do that within the incentives. Just I guess to be clear, what you'd have to do in that circumstance is to be pregnant again, because they are for those who are pregnant. So in that sense, we don't go back and approach because it's the incentive bit of this is restricted to those currently on that pregnancy pathway. It's not a unit. We don't incentivize others. The support is free, so it's a council service that is provided totally free of charge, plus the NRT, which generally would cost you about 45 to 50 quid. So in that sense, it is incentivized because it's getting things you'd otherwise spend money on, but the actual incentives in pregnancy here are just for that pathway.
I guess that my question is, if it's 3 months in, the people are engaged and that this is the opt-out point in time, how easy is it 3 months after that for them to re-engage, or are they asked again? I know that obviously they'll have lots of touch points with the NHS, and as you talked about training across the wider hospital and other healthcare organisations, I'm sure they will have some engagement, but is that something we make really easy? Is there something we can improve in that area?
I mean, from a sort of post-delivery discharge from midwifery point of view, if smoking expectant women have got to their 3 months and stopped or not, they will then be picked up by the Healthy Child Service, and sort of those messages will be reiterated. How's that still going? And just sort of those, that harm and hope that Peter was talking about. So potentially there's that ongoing drip of those messagings and reminders about how to go back into smoking cessation services as well, for as long as the health visitor is visiting. So it's not a cliff edge necessarily. And again, it's about making sure the workforce are really up to date on their sort of brief interventions, know how to refer people into services, and just, keep on encouraging people that if you've fallen off it this time, it's okay. It's just that consistent messaging across the whole of the sort of public health workforce, really.
And I'll quickly just come back in, Councillor Rose, just to say that you highlight an important point about sort of smoke-free homes and this going beyond pregnancy. So asthma admissions for under fives are one of the leading causes of admissions for under fives, asthma exacerbation. Our cost of living report, which we took through the Health and Wellbeing Board last time, showed that there were around about 167 children with asthma who are passive smokers in York, so living in homes with smoking in. So, that's going to be a big burden on our NHS, but it obviously a distressing thing for their health. So it's an important thing to highlight about the smoke-free homes agenda.
Before I pass on, I've got a question of my own. Pardon me. There's a difficult bit here that I feel has not really been covered. It's sort of understood stopping smoking is best. And then you're saying, well, e-cigarettes, vaping, NRT is better than still smoking. But it's a very complicated message, that, isn't it? Because I wrote down a few quotes from Googling things online today. The Royal Women's Hospital says about nicotine in breast milk and passive smoking can give babies chest infections, etc., and neonatal problems. The NHS says while using an e-cigarette is a lot safer than smoking, it is not completely risk-free. As well as nicotine, e-cigarette liquid and vapors contain toxic substances, though they are at lower levels than cigarette smoke. And there were others from Centre for Disease Control, American Library of Medicine, all of them saying, actually, we don't properly know the impact of vaping and e-cigarettes for pregnancy or for breastfeeding babies. We think it's lower, but we don't have the data yet. How do you propose communicating that very difficult message to people who want to make the right choice, but need to be informed about risks in a way that, I have to say, when I read this, I wasn't. I didn't even make the link between e-cigarettes and vaping very easily. And I wonder how many people who vape actually think that when people are talking about an e-cigarette, that's talking about me. Are there messaging things here that we need to get to grips with that would help get better outcomes, I suppose is my question.
Thank you, Chair. I think there are, and have spent considerable portion of the last sort of 3 or 4 years with that really difficult, nuanced public health message about vaping and smoking, and it is probably been a challenge for the public health community to express that, and I'm sure we haven't always got it right. So I'll try and sum up what I think it is, and it's really simple for me. If you don't smoke, don't vape. That's a really good starting point. So you're absolutely right that with products like e-cigarettes, to pick up lots of different types of harms that they might cause within the data at a population level takes a good long time. And Dolan Hill in the 1950s, 2 doctors did the doctor's study to demonstrate that smoking was bad for your health, but that was after sort of 30 or 40 years of speculation that it would be, and it was only really to the 60s and 70s we could conclusively prove, and the government decided to do things about it. So these things do take a time to get through. So I would not in any way go on record and say that vaping is harmless. But I'm very happy to go on record and say it is far less harmful than the cigarette, the single biggest preventable cause of death. A product that we wouldn't license if it came to market nowadays. It's a product you can freely buy in many shops in the city that kills 2 in 3 users if you use it properly. I mean, it's so exceptionally harmful. And so the public health message is, if you don't smoke, don't vape. If you do smoke and vaping proves to be an effective way of quitting, then we'll support you to do that. And if you then do wish to quit, we'll quit vaping, we'll help you to come off vapes too. But vapes are proving to be such an effective part of the quitting journey that we can't ignore their helpfulness here. Otherwise, more people would die from the inaction of use of e-cigarettes as part of the pathway than will die from using them in terms of any potential harms that there might be. So that probably wasn't as nuanced and well expressed as I might like it to be, but it is a difficult public health message. But we very much have to hold those 2 things in tension. If you don't smoke, don't vape, particularly children and young people who are not smoking. There's absolutely no reason to vape, and the marketing of vapes to them is really not acceptable at all. But for those who are existing smokers, I think vapes need to remain part of our quit toolbox. And that's what we use them for in York. It's what the hospital use them for. It's what our GPs use them for. So I think that's pretty much embedded now within the National Health Service as a particular sort of usage.
Thank you. I've got 2 already down. So it was Councillor Wilson first, then Councillor Baxter, and then I'll come back to you.
Thanks. Hopefully a pretty quick one. So I'm really pleased to see that you also support their significant others to stop smoking. And I assume that is partners and possibly parents if they're still at home, and anybody who's in the home. Have you got any stats on how successful that is, given how important it is for helping women stop smoking?
I'd have to defer to getting you that information at a later point, Councillor. No, I don't. Significant others is defined as anyone that the pregnant lady wants to nominate that they live with, or is actually, I'm pretty sure actually it is literally a significant other, so it doesn't have to be in the household. I've checked that out, but it's quite a flexible thing, absolutely based, as you say, on that evidence that smoking is quite socially mediated, and when you're surrounded by it, it makes it much more likely.
Right, yes, Councillor Baxter.
Thanks, Chair. It kind of follows on from sort of your point and what was touched on, but I think obviously sort of teenage pregnancy rates have gone down a huge amount over the years, but then vaping has gone up hugely in sort of teenagers and young adults. And I wonder if we have probably not any data on the impact if you start by vaping rather than smoke and then go to vaping. Especially sort of when you're still developing, we don't know the risk, but is it still better? And what support can be given to those young people who, as you say, the market is just bonkers, it's ridiculous. And, it's sort of trendy to be vaping. So what can be done sort of in schools as well, not just at the at your GP or anything like that? Thank you.
So our public health team have been running a campaign this year, which includes some resources we produce for schools, some educational sessions that we've been running within schools, builds on a national toolkit by Action on Smoking and Health, ASH, that is really well evidence-based, and it is that nuanced message, but particularly because particularly as you go down the age range, the expectation is we're hoping young people aren't smoking. So in that sense, we're very much saying they shouldn't be vaping. There will be instances where, for instance, a 17-year-old who's been smoking cigarettes from 15 years old, switching to a vape at that age is preferable, but that's not the same thing as endorsing a message that vaping and children should go together, and they shouldn't. So that's the main thrust of the campaign is don't vape. This is what e-cigarettes are. There's no point in being coy about it because they're everywhere. We know that that children use them a lot. We're not sure of the long-term harms. We do know there are some short-term side effects. People report a lot more coughing, some nausea sometimes. So there are actually some real downsides to vaping. And also then working particularly through our trading standards colleagues in the council about, I mean, vapes are quite tightly regulated in the UK in terms of the amount of nicotine that you're allowed to put in them. I think the US market allows something like 2, 3, 4 times the amount of nicotine. But we know there's a lot of oversized vapes in the black market where the nicotine amount is way more. And we know that shops are doing things they shouldn't. I mean, for instance, if you see someone under the age of 18 who's vaping, someone has broken the law at some point because it's illegal to sell to an under 18 and it's illegal to sell to someone who then gives it to an under 18, a proxy sale. So we're doing a lot of work to check. We've done something recently, last week, in fact, where we did managed to find a shop that was doing some of that. It was in York Press, so it's public knowledge that we did that piece of work and are taking enforcement action. So there is work on that ongoing.
If I could just add, there's a bin in our ward that is just a standard black bin, but it actually looks white because it's just covered in those stickers that come off vapes.
Yeah.
So it looks like it's a white bin now because it's just covered, and it's it's children who are at secondary school, and I find that so worrying. The shift from sort of when I was at school even to now, it's just anything that we can do to help, I think, is so important.
And the environmental impact of cigarettes
Yeah.
is awful because of I think they're the most littered item, cigarette butts, but the environmental impact of these disposables with their batteries, etc. Absolutely, I couldn't agree more. We're in the middle of a consultation. In fact, it's closed now nationally. One, to enact the single most effective piece of public health legislation in the last 20 years, which is raising the age of stale, which I'm violently in favour of. But the rest of that consultation is about what we are going to do as a nation in terms of the issue of vaping and marketing and sales. And we'll be having some news soon about what that consultation came up with and what the government are looking to put in place around disposable vapes, particularly whether it's a tax, whether it's a ban, various different options proposed and on the table.
Yeah, I'll just make a point then. And I think it was Councillor Steele-Walsh were next, and then Councillor Rose. Yeah, I was just going to see if I've understood the point Councillor Baxter was making, and she can tell me if I've got this wrong. But in a sense, what I think you were getting at was, what if you've just grown up and gone through school and vaping's okay, and it's just part of the way you are, and then at the age of 19 or 20 you become pregnant, you go and see the doctor or whatever, and you see a sign on the wall that says, if you're smoking, we can help you switch to vaping. And then you think to yourself, oh, that's cool, I vape, I've got no worries. And it's how do you balance all of that, which is undeniably complicated, so that the younger person who'd never dream of smoking but is vaping like a non-smoking chimney recognizes that there are nonetheless risks or potential risks associated with vaping and being pregnant. That's yeah.
It's a very good question, and that eventuality you can absolutely see happening, can't you? And it's why our messaging to schools and young people is essentially not to vape. And our messaging to existing smokers is to vape. And we need to try and keep those messaging channels as separate as possible to avoid that confusion. I can take the feedback of this committee back into our services and think how effective are we at doing that? For instance, I know we do advertise our health trainer services around the city on bus stops and things like that. Obviously, bus stops are having people of all ages on them, so we can look to see what's going out there. And our GP surgeries will be having posters up as well. So we do need to make sure that we aren't encouraging children and young people to take up vaping. That is not something we are in the business of doing as a public health team. It's very much against what the evidence would say. We've got to make sure, and there's always the balance of harms here. But the statistic to counter, or not to counter that, but to put that in context, is that every year when Ash has measured the smoking population in the UK, higher and higher percentages of smokers have said they think vaping is more dangerous than smoking, and that's now above 50%. So the majority of smokers thinking that vaping is more dangerous than smoking. That's categorically untrue and will probably lead them to attempt to quit using an e-cigarette less frequently. So that's a dangerous public health statistic in terms of our smoking cessation efforts. It's a really delicate balance, and we've got to try and make it. I hope as a public health team, I hope it gives committee assurance that we're fully aware of the delicacy of the balance, and we're trying to hold those things in tension, but always up for the challenge that we haven't got it right in either way, and we'll try and toe that that line as much as we can.
Okay, Councillor Steeles-Walshaw, then Councillor Rose, and then I think we'll try to wrap this up.
It's more of a comment really, just on from the last two things about cigarettes and vapes and which is worse. And I think it's about the harm reduction message. I'm talking about adults here, I'm not talking about children. And it's about trusting that people can weigh up the pros and cons when they're actually given the correct information. All that stuff about vapes being much worse for you obviously isn't true. And I think that's around communications, around public health, again, about giving people the correct information and letting them make their own, hopefully informed decisions on correct information. Yeah.
Councillor Rose.
Thanks. Yeah, it was originally just a supplemental to say I've completed the consultation nationally. I've had residents email about it. It's really good, and I think it will lead to change at a national level. And not to get political again, but I think it is a problem, and it's a problem that needs to be solved nationally because it should have similar packaging and be dealt with in a similar way to the way that we've dealt with cigarettes. And the fact that it isn't does appeal to children and teenagers, and is a big problem there. So yeah, if anybody hasn't done that consultation, please do give your viewpoint, even if it's different to that. And then the other one was just on the same point that's been talked about on the people who are emerging not as cigarette smokers. That 131 number that we've got as the number of women smoking at booking, the same, having that number of and tracking it over time, how many people at booking are vaping, and being able to see those two numbers, it will be a very different pathway and they won't be comparable down that stack. But that kind of initial number of, is it 3% at the moment and it goes to 10% over the next year or two, I think it's probably worth finding a way of tracking some of those numbers. I guess that also potentially applies to significant others who are smoking, having some of those kind of parallel figures and what's effective and what's not.
Thank you for that. Yes, and I've just got a quote here that I read this afternoon that I'll tag in at the end. The Centre for Disease Control and Prevention in the US notes that nicotine can be passed from a breastfeeding mother who uses tobacco to her infant through breast milk. And the implication elsewhere in that presentation is that nicotine is nicotine. It doesn't really care where it came from. And so that communication is so important, so nuanced. And I'm sure we'll be keen to learn over the year ahead how you're managing all of this, Peter. Yeah.
Thank you, and I absolutely agree with that from the CDC. I guess I would add that so can carbon monoxide, and carbon monoxide is not present in a vape and is hugely harmful. So yeah, I totally agree with that point about nicotine. And I guess what we're aiming to do is produce societies that are not addicted to these substances, which is very much where the health training service comes in. So we do help people both to quit vaping and to quit smoking, and to emphasise that point as well. So just a plug for one of our council services, and please do refer people into those services, and they can self-refer.
Yes, Councillor Taylor, and then we'll.
Yeah, thanks, Jay. Just in terms of wrapping up, Peter, you mentioned you'd like a specific sort of steer from us recommendation so that you could take this back to colleagues at the hospital. Is that maternity ward?
That's right. If the committee were happy to endorse the recommendation that we are encouraging our health colleagues to implement the pathways that are committed to in the long-term plan, I would be able to, in a very sort of partnership way, take that back to the hospital to say Scrutiny Committee have resolved that, and we could potentially write out either from chair or from me as Director of Public Health, just to say the committee have done so. It's very much not in any way meant as a critical point. It's meant to be a supportive point, and we are trying to work as much as we can to support that, the trust in doing that.
Yeah, good point. Have you got that, Robert? Are you happy you've got a form of words?
Could you just go through that one more time, Peter?
I can, Robert. So something along the lines that the committee would note and approve the recommendation to support our local hospital trusts and health partners in embedding smoking cessation in their pathways.
Great. Okay, thanks for that point. I'm taking everyone. I didn't see anyone looking disappointed at that. We all happy that goes in? I think so. Good. Okay. Thank you very much. We'll bring that agenda item to a close, and we'll just worry about the work plan for hopefully a very short period of time. Thank you. So we've got things planned until April. Yes, Robert. There are things we need to know.
No, it's more. There's a couple of proposals for sort of amendments to it. So there is a proposal for the next finance and performance monitor to come to January's meeting. And we've also had basically, I think unless Michael jumps in and tells me he's changed his mind since we talked the other week, there's also one of the TBC items, the adult social care commissioning strategy, could potentially be brought to that January meeting as well.
Cool. Yeah.
And alternatively, we also had Neil Ferris suggest that he could bring forward the building repairs report that's currently scheduled for March. If we'd want to have a look at that in January. I'm just checking if I had anything else. And I believe as well, Michael, I think you also had the adult social care strategy that could potentially go to March, if that was correct.
Yeah, so I think we've got to do some co-production work and early in the new year around the strategies. So it might be out of going to a little bit later in March where we feel like we can be looking at the results.
Okay. So what you've just suggested then would move 4 or 5 things into January. Is that right?
If we were to move, yeah, if we were to move all of them, it would. But yeah, I'd sort of be suggesting, probably asking the committee to consider which ones it would want to consider where. So we could potentially look at both the commissioning strategy in January, and we could leave the building repairs in March. I guess it with the offer standing, I guess it's what the committee would want to prioritise looking at first.
Yeah, Councillor Rose.
Yeah, I guess my preference is to do what we tried to do in the beginning of try and keep them focused on an area of business, and for that would be January, throwing in the 2 CQC inspection, which we probably should have already had, but January is what I suggested last time, and the ASC commissioning strategy, and then keeping March focused on housing, including the stuff that's in there at the moment, the draft rough super strategy, which is effectively homelessness strategy for March, and then we've got the remaining ASC stuff. Feels like it does tally with the stuff that's in April. So I still think there's probably quite a lot in each of those meetings.
Yeah.
But they feel like they flow from one to the other a little bit more perhaps than any other route.
Does that sound reasonable to everyone else? I agree that the commissioning strategy we've been hanging around for, haven't we? So it would be good to get that.
Yeah,
to us in
the only challenge will be if you can get the people at the time. So if we can't get you here in January, then we'll just have to roll with it, I guess. But
Yeah.
if we can aim for that personally, I think that's the cleanest way of doing it.
Yeah, okay. And is the commissioning strategy, that's what Michael would be bringing? Yeah, I think that would be good. And I think that's probably a big chunk to do.
So just to clarify as well, so we're asking that achieve CQC inspection, whether or not that would be available to go into that January meeting. Was that what?
The first two bullet
Or just your?
The first two.
The first two bullet points on that final page, moving those into January, leaving March alone, and trying to except for potentially that draft rough sleeper strategy, which I don't know if it is a duplicate of the homelessness strategy or it is definitively different, but they do feel tied. And then April, we've got a few remaining adult social care strategy, etc. I think probably around that time when we talked about neurodivergence earlier that wasn't on this list, if we're going through that process of an autism or neurodiversity strategy, then April feels like the right sort of time for that as well, potentially. So
To health.
yeah, how we drop anything off this agenda altogether is a different matter. If there is anything that we shouldn't be keeping on here, but
Well, in that case, so we can add the commissioning strategy. We'll go away and we'll ask about the CQC inspection. So I'll need to obviously double check that, as you said, that will be available.
I think the inspection and report is already all available.
It is available. It's whether we can get.
Yeah, because I think it was available in late October, so we've had bags of time now. It's just about whether we can actually get the right person onto the meeting to have that conversation, rather than just us reading a report and noting that there are problems in it.
Yeah.
Fair enough. I wasn't aware of that, but that's fair enough.
Well, so I think that's so. The inspection and the commissioning strategy brought into January, and we'll check that. You'll check that with Danny as well.
Yeah. And then the other TBC items, so basically everything from the second one down, we're effectively at this point going to be sort of keeping them as a list that I guess we'll start to think of as populating next year's when the meetings come out. Because as you said, we've already kind of filled those items quite a lot.
Yeah, and we're already at 8:30, so I think we've all done a good day's work.
Yeah, I think those all tie into the stuff that's in April. The only one that doesn't is the Glen Lowfield stuff. So whether that feels like it could be squeezed into we put to later.
We'll revisit that after the festive period. Good. Thank you to everyone. I declare the meeting closed.